Namaste and greetings from Nepal. It is a great honor for me to be a part of the band Ophthalmologica. I would like to thank Dr. Vaibhav Sethi for roping me in for this program. It truly is an honor. Well, I've been asked to introduce a little bit about my music. Personally, I started playing the guitar when I was 10 years old. And there was always conflicting ideas in my head whether to become a full-time musician or whether to have another career. But at this point, I'm very happy I'm able to do both. I have a band called the Blue Fret. The Blue Fret plays original music. Our music mainly focuses on folk as well as the Western genre. We have 7 members in our band. And the special feature about our band is that we have incorporated our ethnic instruments. For example, the sarangi and the flute. So when you hear the band, you get a touch of both Western as well as the Nepali folk music. Our band plays in different venues in Kathmandu. And apart from just playing music, we also have established a not-for-profit called Music for Medicine, where we set aside money for this organization. Music for Medicine, what it does, it sponsors music studies for those students who are unable to afford to pay their fees. We also support salaries of music teachers at institutions that are struggling to make the music happen. And also, we set aside money for the free treatment of patients. So this has been going on for quite a while now. I remember the first time that we started raising money for treatment was back when I was a postgraduate student in Manipal. That was, I forgot, many years ago. But with Dr. Biju Raju, Rohan Daniel, and we formed a band called the Donesis, like the Faco Donesis, and we were able to raise money and start a fund called the SRF, which is the Site Restoration Fund. So that has continued even now in my career. So I'm very glad that this concept came together by the 3 of us then, ophthalmic residents, trying to do something with our music. Apart from the music, we have also a not-for-profit organization called Ek Ek Paila. It was founded during the time of the earthquake, when Nepal was severely affected by the earthquake, in fact devastated by the earthquake. And a group of medical doctors and like-minded friends, we went to these earthquake devastated areas to provide medical services. And it was all on voluntary basis. After a period of 1 year, we realized that we had become great friends, and we thought, why not register these organizations and do the medical services more seriously? Which led me to follow another path in my life, where I resigned as the head of the Department of Glaucoma, head of the Department of Research at Tilganga Institute, and started my journey as a volunteer at Ek Ek Paila. And today, we are proud that we have traveled extensively in remote areas of Nepal, where we provide comprehensive health service, not just ophthalmology, but the entire outfit of setting up a small clinic in the remote areas and providing ENT surgery, eye surgery, gynae, and minor operations, sometimes even major operations, working with the primary health centers, dental surgery, and also providing the people there with music. So often the band joins our areas, joins our mission to provide music to the community there. And most of the funds are raised through the Nepalese in Nepal and overseas. So we have very much a Nepalese run organization, trying our best not to depend on foreign aid, but we welcome our friends donating from all over the world, but 90% of the funds are generated through the Nepalese diaspora in overseas, as well as the local residents here. Well, this is what it is, and I think now you should just hear the music that Vaibhav insisted that I come and join over here. And music is something that is so abstract. Some people will like it, some people won't. But I do hope you will enjoy the music, and hope you will be able to come to Nepal sometime and attend our shows. And if not for the music, come to Nepal and I can be your travel guide, and I can tell you something and show you around my country. And yes, so that's it, and it's a great honor, and thank you so much, and I hope you guys have a wonderful webinar.
Don't say hello. You've been away too long. Don't say you need me. I've been holding on too long. Don't you try to make it right. Don't say you want me. It's hard not to fight. But don't you dare say the words that I want to hear. You can see right through me, but I couldn't care. And at times like these, I try not to say I need you. At times like these, I try not to say I want you. Don't say hello. You've been away too long. Don't say you need me. I've been holding on too long. But don't you try to make it right. Don't say you want me. It's hard not to cry. And at times like these, I try not to say I need you. At times like these, oh, at times like these, I try not to say I love you. Don't say hello. everything, yet I feel there is nothing a way my life can be. I feel the rain pouring down on me. My troubled mind and soul, it doesn't let me get a hold. A day without you now, it seems like the sun's going down. I try and try to pretend it's alright. The nights are long when the stars don't shine. A new morn was a day behind. I can't understand the way it's out of hand. Maybe you are the reason why. When the nights are long and the stars don't shine, a new morn will show us the light. We can then understand the way it was out of hand. There wouldn't be a reason why. There wouldn't be a reason why. There wouldn't be a reason. There wouldn't be a reason. There wouldn't be a reason why. I got so much going on. I feel alright, I'm walking tall. If you love me, then come right here. Stay with me and make it clear. If you want me tonight, you've got everything going right. I'm in a mood for some moonshine with you every night. So come on, sugar. Can you feel it? Do you feel it coming, honey, baby? I wanna know if it makes me blue. I'm gonna go. I got so much going on. I feel alright, I'm walking tall. If you love me, then come right here. Stay with me and make it clear, honey. Do you feel it? Can you feel it coming, honey, baby? Whoa. Is it true? I wanna know. If it makes me blue, I'm gonna go. I got so much going on. Can you feel it coming? Ooh, I got so much going on. And oh, Melissa, I can't complain. You are my sunshine in the rain, and I can play a tune on a sleepy afternoon to you. Oh, Melissa, Melissa. Oh, it's true. At times I'm lonely, well that's nothing new. My heart feels weary dreaming of you. At times I'm flying and I could touch the moon. Your love comes pouring to wash away my wounds and hard and trying times and all the sleepless nights in a world so unkind when friends can't be found. You take away the blues. Oh, Melissa, Melissa. Whoa, whoa, ooh, it's true. And ooh, Melissa. Oh, it's true. मेरो आवाज सुनिदेऊ, मनको कुरा बुझिदेऊ, मेरो साथ हिँडिदेऊ, कहिले नछोड मेरो एक एक पाइला हेर्दा पनि मलाई पछि नछाड, पर्खेर लैजाऊ मलाई धेरै टाढा तिमलाई सम्झे यही बेला एक्लोपनमा निराश लाग्दा बिर्सेको दिन कहिले पनि सधैँ रह्यो मुटुभरि भन्न सकिन मनको कुरा तिमी नै हौ मेरो संसार आउँदैछु म तिमी कहाँ सधैँलाई आकाशमा तिमी हौ मेरो प्रकाश एक्लो यो जीवनमा तिमी नै हौ मेरो साथ मेरो आवाज सुनिदेऊ मनको कुरा बुझिदेऊ मेरो साथ फेरिदेऊ कहिले नछोड मेरो हात एक एक पाइला
Namaste. Good morning, good afternoon, and good evening. Welcome to the world of Pan Ophthalmologica. Pan Ophthalmologica is not just a webinar, it's a collaboration. It's a collaboration between 20 countries, from Australia to Argentina, from Brazil to Bolivia, from Germany to Greece, where over 100 ophthalmologists all across the globe have come together to share knowledge, share their experience and their challenges with one aim: to learn from each other. Today is the World Sight Day, and we celebrate the gift of vision or the gift of sight. Sight is a beautiful symphony of color, light, and beauty, and it's just like music as it transcends boundaries, languages, and culture. We just heard Dr. Suman Thapa and the Blue Thread Band playing beautifully, and how there's a beautiful harmony and synchrony between music and science. Today, we have over 9 virtual halls with over 20 captivating sessions of ophthalmology, and over the next 2 to 3 hours, I hope you all will enjoy as much as we did to put together this program, and I hope that we see everybody soon, and let us start this symphony of knowledge and creativity. Thank you for your attention. Looking forward to seeing you. Namaste.
Namaste and greetings from Nepal.
Next session, please.
Hello. Hi, Tarjani. Are you there? Hi. Good. I can't hear you.
Hi, good evening, Adit, Prerna.
Hi, good evening, Kirti. Can you hear me?
Hi. Yes, I can.
And
Hi,
tech
Adit. Hi,
support.
Prerna. Hi, Dr. Tarjani.
Hi, Nupur, everyone. So, tech support, can you hear us? Are we live?
Yes, you all are lined up.
Okay. We'll just wait. It's 5:28. We'll just wait for maybe half a minute. Dr. Seema Das is also joining. And at least if not, then we'll start and let her connect meanwhile then.
I think we can start off.
Okay. All right.
It's 5:29. Let's start.
Yeah. So good evening, everybody, and welcome to this Oculoplastic Symposium, which is a part of Pan Ophthalmologica 2023. Now, Pan Ophthalmologica is a meeting that's usually held by the Arunoday Deseret Hospital on the occasion of World Sight Day. This year, we promised to bring 4 very themed topics to discuss and to have some kind of stimulated answers out of this. And with any further ado, we would like to start with the first session, which focuses on venolymphatic malformations of the orbit. So I, Dr. Prerna Tehiliani from Mumbai, and
Dr. Adit Gupta from Mumbai will be moderating this session, and we have exciting speakers lined up. The first session is basically on venolymphatic malformations, which will be followed by a dilemma in lacrimal sciences, which we all look forward to. But mainly the theme of this session would be divided into 2 talks. One is a theme talk, which would be a perspective from one of the persons who's been practicing this art for a long time. And the second would be an interspersed case talks, which would stimulate the theme talks and stimulate our discussions to take this forward. So let us begin the first session.
So I'd like to invite a very close colleague, Dr. Kirti Koka. She's a silent toiler and she has extensive experience in orbit and challenging cases in oculoplastics. So Dr. Kirti will be speaking to you about her challenging cases with orbital venolymphatic malformations. I'd like to also welcome Dr. Sonal Chogle and Dr. Seema Das. So Sonal has been a fellow with Dr. Honawar at Center for Sight and with Dr. Paul Finger at New York Eye Cancer Center. I think it'll be interesting to have her perspective because she's transitioned from institute-based to private practice now. And Dr. Seema Das does not need any introduction. She's the Director of Education and the Head of Plastics, Oculoplastics at Shroff Eye Hospital in Delhi. So over to you, Kirti.
Thank you so much, Prerna, for that kind words. I would like to thank the entire team at ADH and Hadit Prerna for giving me this opportunity. Just sharing my slides. Are you able to see my screen?
Yeah, we can see your screen, Kirti.
Okay. So I'm just going to take you all through a set of cases of venolymphatic malformations, my most challenging case scenarios that I have come across in my experience over the last few years. So before I jump into what venolymphatic malformations are, just a small introduction about them. So they're basically hamartomas and constitute about 1 to 4% of all orbital lesions. So if you see the International Society of Vascular Malformations, they are basically classified as slow flow or even sometimes as no flow malformations. So they can either be lymphatic but the ones with most often that we see in clinical practice are the combined venolymphatic malformations. Their presentations are varied. They can present with proptosis, with ptosis. They can present as a retrobulbar hemorrhage. Most often children come with following a bout of fever or upper respiratory tract infection. Sometimes you can even have a disfiguring proptosis, not just involving the eye, but also other parts of the face. So treatment modalities as such, if you see earlier days, it was just observation because they're very extensive lesions. They're very difficult to treat. People try to surgically excise, but the problem is they bleed a lot. Steroids, radiation has all been tried. However, the current trends have now moved more towards sclerotherapy. I'm not going to go too much into this because Dr. Tarjani is going to talk to us about how the treatment modalities have changed over time. So with this small introduction, let me go into a few cases on venolymphatic malformations. So you can see this young child presented to us. He came to us with severe proptosis, cross proptosis, in fact, over the last 2 months. And this was following an attack of upper respiratory tract infection. So imaging showed the typical fluid levels that you see in most venolymphatic malformations. So the diagnosis is a lymphangioma. So this is how we treated him. So we decided to treat him with bleomycin. So we reconstitute bleomycin with normal saline and plain lignocaine. In children, we use general anesthesia. So we use ultrasound guidance here. So with ultrasound, we generally localize the cyst which is present. And then under ultrasound guidance, we use a 22 gauge needle, which is mounted on a 5 cc syringe. We pass it into the cyst cavity and aspirate the entire cyst fluid out. So once the cyst fluid is aspirated, the prepared bleomycin, which is generally 0.25 to 0.5 international units per kg body weight, is injected. And you can see that the fluid entering into the drug entering into the cyst cavity. So this is how we treated this child. And this is him post 2 injections of bleomycin. And after 1.5 years, he was doing really well. You can see the proptosis is completely resolved and he had no recurrence at 4 years of follow-up. This is another girl, similar proptosis presentation, MRI showing typical features. And this is her post 3 injections of 15 international units of bleomycin. And this is another child, similar presentation with following 3 injections of bleomycin. Now, not always do we have, like what I showed you, all of the deep orbital lesions, but not always do we have deep orbital lesions. Sometimes you can even have the superficial lesions, like those which just involve the conjunctiva. Even these can be treated with bleomycin injected directly into the lesion. And this is this girl post 2 injections. You can see there's no evidence of any lesion now in the conjunctiva. There's complete scarring of the lesion. But now what I've showed you is just a nice picture. So we always hope that we have such beautiful cases that present to our OPD which do really well, but that's not always the case. So let me run you through a few of my complicated cases. So this is a boy who presented again with proptosis, typical findings on imaging, and I went ahead and did the same usual, giving him bleomycin. But this is him coming back to me on the day 2 post-operative period. So he had severe proptosis, he had vomiting, and he was unable to open his eyes. And you can see he has movement restriction in all gazes. So we immediately sent for an urgent MRI. And what my radiologist called me, and this is what she sent me on WhatsApp immediately, saying that he has a severe rebleed into the orbit and he had a huge retrobulbar hemorrhage. So we had to rush him and take him up for an urgent canthotomy, cantholysis, and aspirate the blood from the supranasal and infratemporal quadrant. And post the drainage, this is him doing well. So this is an important thing that needs to be kept in mind, that you can have rebleeds. Hence, it's important to put a nice tight pressure patch on these patients for the first few hours after surgery. And steroids post-operative period really helps to prevent this. This is another child who presented to our clinic with gross proptosis, and you can see the cornea is almost melting away here. And so we we didn't know what exactly was happening. We requested for an imaging, and we found that it was actually a venolymphatic malformation with a bleed into the lesion. But such a horrible presentation, we were wondering what to do for this child. But we still decided to take up the child for aspiration. So we aspirated the cavity and we injected bleomycin. We had our cornea colleagues come in, and since the cornea was melting away for the temporary period, they did a scleral patch graft for the cornea, and we went ahead and did a tarsorrhaphy to close the eye. Later, the edema settled down a little bit, and then we took up the child for repeat bleomycin again a second time, and third time a repeat bleomycin was done. And at this point, our cornea colleagues decided to do a penetrating keratoplasty along with a vitrectomy and silicone oil injection. And this is a child now post 3 injections of bleomycin and post a penetrating keratoplasty. Yes, he has a long way to go, but at least the presentation looks better than what he started. The eye is closed because we still have retained the tarsorrhaphy to protect the corneal graft. This is another patient who presented to our clinic. So he also had a venolymphatic lesion affecting the eyelid. You can see that his is mostly preseptal. It's only involving the eyelid. So as usual, his was more microcystic, not the typical macrocystic, but we still decided to try and treat him with bleomycin. This is him post 2 injections of bleomycin, and you can see both the right and the left images, there's not much of a difference in the appearance. So obviously the bleomycin was not working in his case. So then what do we do next in such case scenarios? So in his case, we decided to go ahead with debulking of the lesion. We made a lid crease incision, and we debulked the entire, because of the bleomycin, the entire tissue was very scarred and fibrotic. So the entire scarred fibrotic tissue was removed, and this is him post the debulking. So you can see that his appearance has obviously improved. He can do a little better on the ptosis, which we have counseled that we could probably take him up for a ptosis correction if he's keen on improving the droopy eyelids a little bit more. And this is again another case scenario, and I don't have the clinical pictures of this girl, but this child presented to us in 2015, and this is her imaging in 2015 March. So she was again treated with bleomycin injections, and this is her a year later. You can see that the intraconal lesion has reduced in size, and so has the supranasal lesion. And by November 2016, you can see that all the lesions had completely resolved. So we were very happy. The patient said goodbye to us and left. And we didn't see her for a long time. But unfortunately, she came back to us earlier this year in Jan. And this is her picture. She came back with a recurrence of her proptosis. And when we did an imaging, you can see that she's got the entire lesions recurred back. So you can see this lesion, the infranasal quadrant, and the intraconal lesion is all recurred back. So this can happen even in patients who resolve completely with treatment. You can have a full-blown recurrence in such patients. And so we have again restarted treating her with bleomycin injections. She's now received 3 injections of bleomycin. And this is her in October as of now. Post the bleomycin injections, the lesions have reduced in size. The infranasal lesion is completely resolved. There is still an intraconal component, which last week she received the injection for the intraconal component. That's the 3rd injection. But you can also see that as you treat these patients with venolymphatic malformations and they start improving, but the one problem that we start facing in these people is that they start developing a superior sulcus deformity and hollowing. This is because as the lesion resolves, the fat also gets absorbed. So she will require further cosmetic corrections using fillers or fat grafts, autologous fat graft for correcting her sulcus deformities. So these are a few of the cases, challenging cases that I have seen during my period of doing oculoplasty cases. So based on this, I would like to conclude saying that venolymphatic malformations can have varied presentations. It's very important for us to assess each of the cases and plan our treatment for each patient, because certain patients respond really well to bleomycin, some patients don't. And if they don't respond to bleomycin, then you would probably need to think of other alternatives that can be done. Sometimes you need to do a combination of doing bleomycin and debulking of the lesions. Rebleeds can occur in these patients, so it's important to monitor them in the important post-operative period, because if not, they can have vision loss, and hence a canthotomy is very vision saving in such patients. And long-term follow-up to prevent, to look for any recurrences. And most important, it's important to counsel these patients that these are malformations that you cannot completely remove. You're not doing surgery it's not a well-defined mass that can be completely removed. So there might be small residues which would probably not be treated, especially the microcystic lesions or the multicystic lesions, and hence can to the residues. And it's important to counsel all these patients regarding this. Thank you.
Yeah. Thank you so much, Kirti, for such a crisp talk. I think we'll move on to the next speaker. Now, how do I introduce her? She's probably definitely nothing short of an authority on venolymphatic malformations of the orbit. She also super specializes in disorders of the socket, and I'm very privileged to call her one of my mentors. So Dr. Tarjini Dave will be speaking to us about her experiences and how the trend from different modalities of treatment have changed over time in orbital venolymphatic malformations. Towards the end, we would have discussion and a couple of quick questions. Over to you, Dr. Tarjini. Thank you.
Thank you, Prerna. I'm hoping I'm audible.
Yes, you are.
All right. So Kirti has actually made my job really easy. Thank you everyone for having me here. You will see a little bit of repetition between what she has said and what I'm going to talk to you about, but then repetition definitely helps in subjects like these. It helps you get better and probably make you a little more perfect. So I'm going to start with that one girl who came to me saying, can you make me look better? And based on that theme, I'm going to talk to you about the conundrum that lies around venolymphatic malformations, how we've evolved in our practice pattern, what we do in terms of dosing and technique of sclerotherapy, and what should be the endpoint you should be expecting, and some complications you want to watch out for. And I'm going to share with you some lessons that I have learned, 8 points specifically, and these will be in the form of case examples as we go ahead. So this is my patient. You saw her photo earlier, a very sweet girl from West Bengal. And these were her old photographs that her very doting father had preserved. And her main issue was that she was seeking a normal appearance. Vision-wise, she was perfectly normal on both the sides. And if you look at her clinical presentation, she has a mass in the conjunctiva, the eyelid, and obviously in the orbit, because you see this large dystopia. One of the quadrants of the conjunctiva, this particular part, you can actually see the lymphangiectasia with dilated lymphatic channels, which are blood-filled. She had some pressure on the globe from the lesion, and that was leading to choroidal folds at the posterior pole. This image here, or this slide here, shows you how extensive the lesion is. And this is my first learning point, that when you see a mass which is everywhere, ill-defined, intra as well as extraconal, all around the orbit, unruly, does not behave well, does not look well localized, the first differential coming to your mind should be a vascular malformation. So in this particular girl, we were looking at the several medical and surgical treatment options that have been described in literature, and we were wondering what we should go ahead with. However, she came to us at a point of time where we had actively started performing bleomycin sclerotherapy, and that's exactly what I did for her. And the sequential panels show you her resolution after 4 injections of bleomycin sclerotherapy. So this is what we began with. This is what we ended with. I was very happy with it, but she wasn't. She did pick up this dystopia and told me, can you correct this as well? So I started wondering, okay, what can I do to bring the globe higher in position? Obviously, the orbit on the left side is much more enlarged and expanded because of the long-standing nature of the vascular malformation. So I decided to place a wedge implant for her, and I could correct the dystopia a little bit. It's a busy slide, but don't get carried away by it. This is the first presentation. This is the last presentation. You can see that the lesion, which looks much larger, has slowly consolidated towards the end of sclerotherapy. You can see these areas of intraconal fat now appear, which tells you that the lesion has shrunk in size. And what I wanted to show you was this wedge implant that I placed in this expanded orbit to make her orbital volume reduce and to bring the eyeball up so that she looks better appearance wise. So I was quite happy, but she was not happy with the residual asymmetry in the eyelid fold, and she requested, could you do something for it? And we went ahead and did an eyelid fold formation. This is her last picture to me. She lives in Calcutta, as I told you. So this is a picture which she clicked of herself and sent to me. All in all, this is what happened over a span of maybe a year and a half or something like that. And this is the kind of result we could give her at the end of this treatment with bleomycin sclerotherapy. Now, with this background, I just wanted to recapitulate certain things that Kirti has already mentioned, so I'll go faster. Lymphatic malformations are benign, so you're not worried about a malignancy. These are usually vascular hematomas, which are thin-walled, and because they are thin-walled, they tend to rupture. They're also very ill-defined, making surgical debulking very, very difficult. They can be in the orbit, and they can be in the adnexa, in the eyelid, as well as the conjunctiva. And they're slowly progressive and diffuse. They just keep on growing everywhere into the orbit. The difficult part radiologically is to identify what's the venous component and what's the lymphatic component. And why do you want to identify that? Venous component has some connection to the systemic circulation, and you want to be careful when you're using sclerotherapy because you don't want your injection to go retrograde into the systemic circulation. They have a lot of morbidity associated with untreated lesions in terms of globe dystopia, in terms of blepharomegaly, just in terms of the unsightly appearance, which kind of makes it very difficult to have a good quality of life for these patients. And you do have a threat to vision when some of these tend to rupture and put acute pressure on the optic nerve and perform and lead to a compartment syndrome. So traditionally, what we have been taught with was, or what we had been taught with was to debulk these lesions or to decompress the orbit. So essentially either remove the lesion or make the orbit larger. But that is associated with a lot of surgical challenge in terms of bleeding. These are vascular, these are ill-defined, these are cystic. Surgery is extremely difficult and complicated in these patients. And therefore, you might want to opt for situations where you can handle these without actually being very invasive inside the orbit. And that's the first positive for sclerotherapy versus debulking. When you have lesions like these, which are diffuse in the conjunctiva, even if you debulk these, you're going to leave the patient with a large conjunctival defect at times, because these are not only subconjunctival, they can actually be involving the substance of the conjunctiva, and that might lead to a limbal stem cell deficiency. So versus that large excision, if you had the option of just performing sclerotherapy like Kirti mentioned, you can actually have the entire lesion regress in a much more minimally invasive format. Now, these kind of lesions, even a very experienced orbital surgeon is going to think twice before entering an orbit like this, where you're not very clear of where the nerve lies preoperatively. How would you control bleeding? So again, another plus for sclerotherapy versus debulking. Certain lesions which are perineural, everything is difficult. Even injecting into these lesions is difficult, but it's definitely less difficult than going in and surgically removing lesions which are around the nerve, because you're worried about vision in these patients. Those lesions which are combined, orbit as well as adnexa, again pose a challenge, and you don't want to perform very severe debulking surgeries in different parts around the eye, for the simple reason that it gets very complicated, especially when it's a vascular lesion. And that's again another plus, where you can just inject into these lesions and get the response that you're looking for. Macrocysts are a delight to treat with sclerotherapy because they respond very, very well and are a devastation to operate upon because they bleed like crazy. So there again, sclerotherapy scores over debulking. While it is said that macrocysts have a better response, microcysts also respond to sclerotherapy, as you're seeing over here. And in my hands, I would always give the patient a trial of sclerotherapy before debulking a fibrosed lesion out if it's coming in the way. The other beauty is that when you perform sclerotherapy, it's absolutely scarless. You don't see any scar of your surgery. And of course, it saves you a lot of surgical time and therefore morbidity in the orbit, because all you're doing is aspirating and injecting. One would want to know what the long-term outcomes of these are. And I can tell you from a fair amount of experience that the recurrence rate is very minimal. And even those recurrences tend to respond well to a repeat session of sclerotherapy. It's safe, it's accurate, it's precise, and it reduces the surgical challenge for any orbital surgeon. If someone asks me what's the one downside, then yes, the major downside in my mind would be that you need multiple sittings of bleomycin sclerotherapy to get the result that you're looking for. So that would be the only thing that I would think about. Now, having discussed debulking and the progress to sclerotherapy that we've made, I just wanted to tell you what happens if you do not perform sclerotherapy. Say you plan for surgically debulking a lymphatic malformation like this. You do get a good response once the surgical edema settles down. But what happens is the patient comes back with a recurrence and a rebleed, because some amount of the lesion always stays inside the orbit. You can never excise these completely or debulking them. And this is the preoperative radiology and postoperative radiology showing you that there is still some amount of lesion inside the orbit. So these are vascular malformations. They can always bleed again. Sclerotherapy fibroses the vascular malformation and reduces its potential to rebleed. So that's the one thing that, in my opinion, works best in favor of sclerotherapy. Just to complete the list, we've all been speaking about bleomycin because it's easily available to us. There are several other sclerosing agents, some available to us, some not available to us, but bleomycin by itself has given excellent result, and that's what is being used most commonly around the world. There are also certain medical treatment options available, which are still in the trial phase for lymphatic malformations at present. And eventually you can have multimodal treatment with a combination of all of this to give your patient the best outcome. I just wanted to briefly speak a little more about bleomycin. Its use in vascular malformation is drawing a parallel from pleural effusions, malignant pleural effusions, where the fluid is pulled out or sucked out and a little bit of bleomycin is injected to sclerose the walls of the pleura, therefore avoiding a pleural effusion from occurring again. And it has shown very good response in pleural effusion. The response in orbital lymphatic malformations is the same as what you see over here, about 84 to 93% when you use bleomycin. This was the very first case that I explored for bleomycin sclerotherapy, and the reason to not debulk was it was all around the punctum, and I was quite worried about damage to the punctum and canaliculus. And you can see that just one injection gave a beautiful outcome. So now what's the treatment protocol that we follow? There's quite a bit of literature we've put across on bleomycin sclerotherapy. I'll briefly tell you what we do. You get a 15-unit injection, which is either diluted with 15 ml or 7.5 ml to make it in a concentration of 2 units per ml or 1 unit per ml. And then you decide how much you want to inject into the patient. I follow a very simple way of injection. If it's a localized lesion somewhere around the conjunctiva and eyelid, I would inject 2 units in each lesion. If it's diffuse, I would inject 4 units. If it's orbital, I would inject 6 units. And for any additional lesions, say a brow, temporal fossa, cheek, I would go and add 2 units each in these lesions. Kirti's already told you about the injection technique, so I don't want to get into the video, but it's very similar. You don't always need to use image guidance. You can perform a non-image guided transcutaneous or transconjunctival aspiration, because we are all orbital surgeons trained to read radiology very well, and then inject into the lesion based on the calculation that we just discussed. So I won't go into the details of micro and macrocystic here, but I just wanted to tell you how we assess outcome. So once you've done all of this, if you see more than 3/4 of the lesion has disappeared, you are going to call it excellent outcome. And then subsequently, you have the good, fair, and poor outcome. If you have residual lesion, you repeat bleomycin sclerotherapy. Again, you go ahead with a second sitting and you see what your outcome is like. And eventually, if you see a residual lesion, then you go ahead with the third cycle and inject. When do you stop injecting? You stop injecting when on tactile sensation while you're injecting, you feel a very firm mass that tells you the vascular component has collapsed, the fibrotic component remains, and at that point of time, you probably want to go ahead and excise if there is any residual lesion. So in those patients who give a very good response, what should be the endpoint of treatment? You see, this child has had only one injection and she's left with a large hollow. That is because she had a large macrocyst which was aspirated, injected into, the orbit is expanded, and she probably is not going to have a very good cosmetic appearance because of that hollow. So we tried to study this as well. And what I can tell you as a conclusion is go by your clinical assessment, don't go by the radiology. You're not removing this lesion completely when you perform sclerotherapy. Some amount of residual lesion is always going to be there, and therefore don't use radiology to continue to treat these patients. Go by your clinical features of how much the proptosis or the lesion has reduced by. And what are those factors that are predictive of good outcome? On a multivariate logistic regression analysis, the only factor predictive of good outcome or predictive of a poor outcome, I should say, is chronicity. If it's a chronic lesion, it's likely to have a poorer outcome as compared to an acute lesion. And some of the things that I've seen along the way are periocular inflammation, like Kirti mentioned, and pigmentation that occurs because of bleomycin. Inflammation treated with steroid, and pigmentation resolves over a period of about 6 months in these patients. So coming back to our patient, yes, you can bring an improvement in the appearance of these unsightly lesions for patients with venolymphatic malformation. The outcome does take time, but if you go stepwise, as we saw in her case, you can definitely treat the orbit and the adnexa. And to conclude, lymphatic malformations are difficult, but they do require multidisciplinary approach for treatment. Sclerotherapy has excellent outcomes and a very limited side effect profile. The dose depends on the extent of the lesion. The agent of choice depends on the center and the availability to that center and the side effect you expect to see in the patient. And oral medications and targeted treatment do hold promise for the future. This is the girl. She is a painter, and she came back to me with a painting of me. And that makes a happy patient and a happier doctor. Thank you so much. And I'm sorry to overshoot the time by a minute.
That's completely acceptable, because this was really a lot of great cases that were discussed. So what I would like to do probably now, we can invite Dr. Sonal for her comments, and then we would have Dr. Seema Das, who's here with us, and she's heard both the talks. Maybe we can have a quick minute after that for a couple of questions from others as well. Over to you, Dr. Sonal Yadav.
Thank you, Dr. Prerna and Dr. Adit, for the kind invitation and for the wonderful session in the two very, very crisp talks that we have had. Dr. Koka has very efficiently presented a series of challenging cases for these orbital lymphovenous malformations. So basically, from what I know, what the very important takeaway here is, these diseases require a lot of patience, both from the operating surgeon as well as the patients. That's a very important point, because it's many a times it's a multi-staged procedure. And with the second talk, yes, Dr. Dave has published extensively and worked extensively in the field, and definitely the pointers were pointers are very, very important. I especially liked the multimodal management, where you also apply the wedge implant to correct the dystopia that the patient had was left with, because that just tells us not to pinpoint or not to just focus on the said disease per se, however, to holistically manage the entire appearance and whatever the patient needs. So Dr. Koka, with your experience, I wanted to ask a couple of questions. So in the patient that you said that he rebled on the post-op day 2, was that also an ultrasound guided procedure, or was that
Yeah,
so
we aspirated the blood also ultrasound guided and did a capitalizes. Yeah.
So in cases you have had encountered rebleed, have you very able to identify any risk factors? Looking back
So
at
we
those
did get
cases?
a bleeding profile prothrombin time, which is all normal in his case. So
Right.
I'm guessing it was just a bleed into the lesion again. and there was no
Right.
other cause for it because he was still, we had discharged the patient, but he
Right.
didn't give any history of coughing or anything where there was any strain put on his eye. So because it was immediate post-op, so I couldn't. So first thing we thought was a bleeding disorder. So we got his entire coagulation profile done, but it was all normal. So
Right. Okay. Anything procedure related, Dr. Dave? Would you want to elaborate? Is there anything that can be avoided or can be identified as a risk factor for a rebleed in these cases? Because when we want to go transcutaneous and not open up the patients, these are some of the pointers we want to keep in mind for repeated injections. Anything that you have identified that can minimize this complication?
Yes, Sonal, that's a very interesting question. The only thing I would think on lines of was sudden decompression of the lesion. So if you aspirate at a very high rate or at a very fast rate and you decompress the lesion suddenly, there's a chance of it rebleeding. The gauge of the needle that you use can always be a point.
yeah,
of
a wider gauge can also.
It's too larger. Yeah. And is there any correlation between the color of the blood that you get to aspirate? I mean, obviously that will show the chronicity of the lesion too, depending upon how long it has been. But has that been a component? If it's like a little bit of fresher blood that you have aspirated, and that might have led to rebleed in the post-op period.
Would be.
Yeah. Most often I don't see fresh blood. We only see altered brownish kind of blood. The video that I showed was actually one of the few cases I had the typical straw colored fluid, but most often it's not. It's always altered
chocolate
blood.
colored,
Yeah, chocolate colored. Fresh blood is very rare. I've not seen that much of fresh blood. Unless you have a patient who comes to you within few days of presentation, then you get a really a proper fresh bleed and the patient can actually get to your clinic within 1 day, 2 days. Then yes, and you diagnose it quickly, you have a fresh bleed.
And has that been a factor to predict probable rebleed in early post-op period?
No. In fact, actually, this is only my second or third case. The first was the very first case. I remember I was a fellow and we had taken up, and that was the very first patient we were planning bleomycin. And we didn't know that we had to give steroids post-operative because it was all new. And that patient had a massive rebleed, and we didn't realize that we need to patch the patient for at least a few hours. So we hadn't patched. And so I think all of that together had caused a severe inflammation. And that was our learning when we realized that we need to give patients steroids in the post-operative period, at least for a minimum of 2 weeks, and keep the eye patched for a little bit of time. So to prevent all of that sudden decompression changes.
Great.
Thank you, Sonal, for all these points. I'd really request Dr. Seema Das to add her comments to this and maybe give us some take-home messages and the final closing comments.
Thank you, Adit and Prerna. In fact, I don't have any comments. I think Dr. E and Tarjani has covered it so beautifully. I learned a few things, in fact. I have, again, a few questions rather than comments. So just to highlight, if you can highlight or emphasize, what is the role of an imaging, CNS imaging also? Do you routinely do it for all your patients who has an orbital venolymphatic? And what is the implication for those patients? Do you really kind of consider the possibility of CNS bleed also and take an appropriate referral for those patients? And the second is for the posterior lesions where possibly there is a predominance of venous component. How easy to do an ultrasound guided sclerotherapy? Because the ultrasound has its limits of penetrations. Mid-orbit or so, probably it's easy to find those lesions, but if something is there bang in the posterior orbit, do you kind of face any difficulty on how do you tackle those patients?
Seema, since we are running out of time, I'll keep it very brief and I'll tell you that I'll answer the first question. In imaging of the CNS, so there is a cerebrofacial venous metameric syndrome where you can have multiple venous malformations in the patient, including the CNS as well as the orbit. A routine workup for any patient that I perform sclerotherapy for always includes an MRI. If required, we give the radiologist the free hand to do an angio if they think it's not a venous predominant or a lymphatic predominant malformation, and give us inputs on that. And we also do a Doppler of the lesion. Even if it's just an orbital lesion, we get a Doppler done to know the flow inside. So the metameric syndrome, yes, I have one patient in whom there was a metameric syndrome. I injected bleomycin and the outcome was disastrous. The patient had a rebleed, the orbit was tense. So that's the only experience I have. I don't have much experience with ultrasound guided. Most of the times we use our clinical acumen and clinico-radiological correlation to inject. And if it's a deeper lesion, I do what is called as an open bleomycin. I just open up the orbit, go expose the lesion, and then inject it to it.
Thank you. Thank you, Dr.
So sometimes for the retrobulbar lesions that we have, which sometimes is difficult to, we are scared to go retrobulbar. The other technique that we do is we open up the subtenon space. So sometimes you have lesions which are just around the orb, right? So we open the subtenon space and we use a blunt cannula. We go in the subtenon space and inject it directly into the intraconal space. So that's another thing that we tried, and it actually works for those lesions.
Thank you so much to all the speakers and our expert panel for the discussion. Now from something very complex, we move on to something that interests a lot more people. So we go to our next session. We have our speakers here, and Dr. Aditya is here to kickstart the next session for us.
Good evening, everyone. So now diving into the nose from the orbit, we have our first speaker, who's a very close friend of mine and also my teacher when I was a resident. Dr. Manpreet Singh is the professor at PGI Chandigarh, and he is going to be speaking to us about challenging cases. He has a couple of cases where he had some challenges which he faced, and he'll be kickstarting our lacrimal session. So without much ado, let's have him hear about his challenging cases, which he's experienced during his clinical practice.
Yeah, thank you, Adit. Thank you for the introduction, and I hope everything is fine. Can I go ahead?
We can hear you. You can go ahead, Dr. Manpreet.
Yeah. So basically, I'll be sharing two cases of mine, not much challenging in the management, but the post-operative management, what I would be focusing upon, that was challenging in these cases. Coming to first case straight away, he was a 60-year-old farmer, was having mass on the medial side of the right eye, basically in the lacrimal sac region. It was originating from here, and it was insidious in onset, was not associated with any pain or redness. There was no history of any hemolacria or trauma or anything else. On examination, this oval shaped mass was around 20 by 17 millimeter. It was having well-defined margins superiorly and laterally, but inferiorly, it was going in the nasolacrimal duct. Basically, it was ending in the lacrimal sac, and it was extending below and above the medial canthal tendon. That is pretty obvious, and overlying skin appears to be stretched, but there were no dilated vessels or anything, pulsatile was not visible. It was a solid mass. So he was carrying a CE MRI, which was done outside, and this showed a pretty much localized lesion, I must say, which was hypo at some points and hyper in the infero medial part here. You can see in this image. However, the nasolacrimal duct was free. So this was pretty much localized to the lacrimal sac. So this was a lacrimal sac mass with the, here you can see in axial sections also, it's localized to the lacrimal sac, not going into orbit or nasolacrimal duct. So what we did was we planned a right DCT, as it was having well-defined and it was a localized mass. Intraoperatively, we found that the orbicularis oculi is stretched, and the tumor actually, the mass was coming out from within the muscle fibers. At some points, we tried to retract the muscle fibers and got the mass out completely. And as it was obvious that it was complete resection of the sac itself, so this DCT was done, and this is how the mass looked on gross examination. It was 25 by 21 millimeter in size. It was lobulated, was firm, and on histopathology, we got this report. It was covered with these images are representative basically. It was having sheets of plasma cells which showed eccentrically placed nuclei with moderate nuclear pleomorphism, and there was infiltration into the skeletal muscles which might be attached to the surface of. So these features were of anaplastic plasmacytoma. So I think it was first of mine which I experienced any plasmacytoma coming from lacrimal sac. So I didn't know what to do. So went back and looked up. There were not many cases, but it had in literature it was mentioned that local recurrences can be from 20% by surgery alone. It can be reduced to 6% for combined treatment, and chemotherapy is indicated only when there are multiple lesions at other than the primary site. So primary site here was sac. The overall prognosis is good once the multiple myeloma has been ruled out. So got the tests, got his bone marrow also. He was not having luckily multiple myeloma. However, the 5-year survival rate in other systemic, if there is systemic or secondary lesions, it's approximately 50%. So that's pretty scary. It was, but extramedullary plasmacytoma of lacrimal sac and duct. This is one of the publications. It showed that they got the biopsy from the nasal part. So this was pretty, I was thinking that what to do and how to follow up the patient per se. I'll jump to the second case. So we'll discuss it at the last, what are the things. And case number 2 is 28-year-old housewife. She was shown to me by a resident when I was going back. So she was having chief complaints of watering and discharge. She was having this kind of, typical and very specific lesion of lacrimal sac abscess. And she has a history of multiple irrigations and had mucoid discharge with continuous epiphora. There was no facial trauma surgery. Punctum, everything was within normal limit. And you can see here the cryocutaneous fistula also, from where the discharge was coming out, it was letting out. I took her as like it's a normal case. Okay, got her diagnostic nasal endoscopy. Is there anything abnormal, which we routinely do for now our external DCR cases also. So as planned, we kept her for drain the abscess. That was done on the same day by needle drainage, and she pretty much recovered. And we planned for DCR at a later date externally. And intraoperatively, surprisingly, what I found that after making, it was ruptured intraoperatively, this huge lacrimal sac abscess. And what I found was this funny, fragile looking, things coming out from sac. So this I kept on removing and used suction for a bit, but it was not a granuloma per se. First, once or twice, I think I excised. Then on table, what I thought that it's having a look of papilloma also. What to do? So that then we converted on table her for a DCT. Informed her on table that there's something suspicious mass. So we are planning to remove your sac completely. That might be taken care of by any additional surgery later on. So we converted it to DCT, and histopathology of this, they told us that's a squamous papilloma, which was of exophytic type. Otherwise, inverted papilloma is a known thing for mucosa related, cystic cavities in nasal mucosa also, and sac, inverted papillomas, but squamous papilloma is not very common. So what afterthoughts I had that what was the indications of imaging in this case? And what type of imaging would probably, and if there any change in management could have been based upon the imaging done prior. So these are just 2 small cases, and I think it's open for comments and
Thank you, Dr. Manpreet. We will have our next speaker, Dr. Nupur Goyal, who is also going to present one case on lacrimal sciences. She is an oculoplastic consultant at Eye Care Hospitals in Noida and a very good friend of mine. She's also very active in the UOC circle and is trying to bring oculoplasty up in that circle as well. So please, Dr. Nupur, please present your case, after which we will have Nandini, and then we'll have the panel discussion.
Hi, so I hope my slides are visible and I'm clearly audible.
Yes, Nupur, you're audible.
So a very good evening, everyone. At the outset, I would like to thank Team Arunodaya, Dr. Vaibhav Sethi sir, Dr. Aditya, Dr. Sahiban, Reena Sethi sir, and Arun Sethi sir for giving me the opportunity, Aditya and Prerna for giving the opportunity to present at this forum. So before I start, so I have named my case presentation as Piece the Puzzle. Often you will not know it's there, and why I have named it so, we'll come to it in subsequent slides. So before I actually move on to the presentation, I would like to give a certain acknowledgement. So Dr. Tarjini Vivek Dave, we heard her giving a beautiful talk. So this case was seen by her and me when I was doing my fellowship at LV Prasad Eye Institute and the Cryology Institute at LV Prasad Eye Institute, Hyderabad, and the photography and the CAVU team of the LV Prasad Eye Institute. So the case is of a 9-year-old male child who presented in 2017 with left eye pain, swelling and discharge near the lower lid since 2 days. The child had been having recurrent episodes in the last 2 years, and the syringing was documented as patent since 2012, the last being done 2 years ago of presentation, and this was done elsewhere. There was no other significant history, everything else was normal, and currently he was on oral and topical antibiotics as you would treat an acute cryocystis case. So the ocular examination vision was normal. On external examination, there was a lower lid swelling and there was matting of eyelashes with redness. So as you can see, these are the external photographs. The rest of the anterior segment and the posterior segment examination was within normal limits. So clinical diagnosis of left acute on chronic recurrent cryocystis with a patent syringing was made. So now we know that why the cryocystis occurs. There's a vicious cycle. There's a nasolacrimal duct obstruction, so which leads to stasis of tears, colonization by pathogenic microorganisms leads to acute cryocystis, and the recurrent episodes further aggravates the NLD obstruction. So the cryocystis, we know if there's an NLD obstruction, there should be a syringing which is not patent. So here comes the first piece of the puzzle, which would be we were dealing with acute cryocystis with a patent syringing. So we further investigated this first piece of puzzle and we tried to look into the causes. So the various causes could be, one could be an atonic sac. So wherein this could be a condition where the syringing could be patent, but there could be episodes of acute cryocystis. So we further went on to the literature search. So we came out with various case series wherein infected atypical ethmoidal cells could also lead to recurrent cryocystis, and the syringing would be patent in such cases. Then the cryolids can also lead to patent syringing because there could be movement of fragmentation of the cryolid, which would lead to patent syringing, and postural variations would lead to intermittent symptoms. And various congenital lacrimal anomalies, we came across case series of case reports of lacrimal sac diverticula. So these were the things that we found that could lead to acute cryocystis with patent syringing. So we further decided to go to the second piece of the puzzle and went ahead with the imaging with a DCT, CT, the cryocystogram. So on this, we realized that there was a lacrimal sac diverticulum, which was noticed, as you can see, with the red arrow marks. So with these two pieces of puzzle, we were fairly sure that we were dealing with a lacrimal sac diverticulum. So we went on the literature search, and there are a few case series and case reports reported, not much. So I'll just skip all this and come to what a lacrimal sac diverticulum actually is. So lacrimal sac diverticulum is basically an outpouching of the which is communicating with the lacrimal sac. It was first described as early in 1772. A lacrimal sac diverticulum etiology can be either congenital, traumatic, or inflammatory. The congenital being the most common. So this is the development of the nasolacrimal sac and the duct, and during this development, when an outpouching occurs, it is the time that the sac diverticulum develops. So it's been noticed. So again, we reviewed series. So it's been noticed that lacrimal sac diverticulum is often asymptomatic and may go unnoticed. However, and that's why you will often not know it's there. So congenital diverticulum of the lacrimal sac, if there's an intermittent obstruction of the drainage, there is vascular engorgement and retention of secretions, which leads to increase in the pressure and symptoms. So as we said, normally it's asymptomatic, but yes, the presenting symptoms can be epiphora, swelling, or a lacrimal cystitis with discharge. So a lacrimal sac diverticulum is, if it's there and if it's large enough, it will be fixed to the deep tissue, but not to the skin. It will be tense and fluctuant when clinically apparent, and it will be lateral to the lacrimal sac. And CT BCG is necessary for the diagnosis. So coming back to the case, we went ahead with the surgery in which Dr. Tarjini did a diverticulectomy. I'll quickly skip through the video. So it was done like a DCR incision was taken and just a diverticulectomy was done. In the interest of time, I will just skip through the video. So, post-operative, this is the picture, post-operative day 1 at 1 week, the wound was well healed and the patient was asymptomatic, and post-operative 3 months, again, the patient was asymptomatic. The diverticulum, the tissue that was excised was sent for histopathology, and it came out to be the lining was similar to lacrimal sac. Thus, this came to the our fourth piece of puzzle, that we were actually dealing with the lacrimal sac diverticulum. So again, a very interesting photo essay was published by Dr. Javed, wherein an infected dermoid was, it was seen to mimic a lacrimal sac diverticulum, which was diagnosed to be a dermoid on histopathology. So with this, we have these 4 pieces of puzzle, so which led to the diagnosis of lacrimal sac diverticulum. So the take-home message in the form of pieces of puzzle. So acute lacrimal cystitis with patent syringing, lacrimal sac diverticulum is a rare but an important cause which one must keep in mind. The second piece of puzzle is that imaging is an important diagnostic tool in suspected cases of lacrimal sac diverticulum. The third piece is that the surgery, a diverticulectomy may suffice, and you may need to do a DCR in all the cases. And the histopathology is essential for diagnosis. The pathology of the cystic wall should be identical to that of a lacrimal sac. So thank you so much for your patient listening.
Thank you, Nupur, for this interesting case. Now, a lacrimal session cannot be without a DCR, right? But our next speaker is trying her level best to eliminate this surgery from our armamentarium. Our next speaker is Dr. Nandini Bothra, who is a consultant at LV Prasad Eye Institute. And now, I don't know whether to introduce her as an ophthalmologist or a dacryologist or a sinus specialist, because she's currently in Boston pursuing her fellowship to understand the sinus anatomy better. So with this, I would like to introduce her. She's going to speak about nasolacrimal duct recanalization. When I was at LV Prasad a couple of months ago, I saw Javed and Nandini both try and introduce this concept to me. And we will have her illuminate us more about this concept and how they have decided to proceed ahead with this. Over to you, Nandini. She's going to chatter her way through this talk because she's sitting in minus 10 degrees at Boston. So I hope we can make out what she's speaking. Nandini, your voice, you have to unmute yourself.
Yep, sorry, I forgot to unmute. Yeah. So it's not minus 10 yet, but it's minus 10 for me. So thank you, Adit and Prerna, for giving me this opportunity. So I'm going to talk about something that is very new, and that could be a possible alternative to DCR in the long term. Well, we don't know yet, but let's hope that it is. So what is DCR? DCR is basically creating a bypass between the lacrimal system and the nasal cavity. And while doing this, we actually bypass the normal lacrimal system. So the normal lacrimal system is no longer functional here. So the basic principle of a nasolacrimal duct recanalization is to preserve the natural anatomy of the lacrimal drainage pathway. And it is more of a minimally invasive approach if we compare it to the DCR procedure. Now, this has been attempted, and the various forms in which it has been attempted is probing with stents, trephination, endoluminal drilling, intubation, and balloon dacroplasty. But if we actually go through the literature, there were a lot of problems associated with these procedures, because in a nasolacrimal duct obstruction, there is fibrous tissue in the nasolacrimal duct, and we use microdrills or probes or trephines, which mechanically dislodges this fibrous tissue and obstruction. Now, when we are doing this, we have no view of the nasolacrimal duct. So there is always a potential of trauma and a false passage. Also, once this fibrous tissue is dislodged, there is a raw area or a pro-inflammatory area, which is amenable to restenosis and recoil. Now, when we put stents inside and keep it for long term, it will help to keep the fibrosis at bay for a temporary time, for a very small amount of time. But if we keep it for a longer time, we know that there is a biofilm formation which occurs on the stent, which will cause re-inflammation or reflex inflammation, and that will cause refibrosis. So all these procedures which have been attempted so far, the long-term outcomes have not really been encouraging. So what is the next step that we can do in order to prevent this refibrosis or recoil which happens in the nasolacrimal system? So let us look at what is coronary angioplasty. If we look at the vessels, there is fibrosis happening in the vessels. But what do? Initially they use the balloons to dilate these obstructions, but there was a high incidence of recurrence and vessel remodeling. So then they came up with something called as the metallic stents. Now what they do is these metallic stents are actually mounted on these balloons which were used earlier. So they go into the vessel, they dilate the balloon, and the metallic stent just somehow stays there and the balloon comes out. So this metallic stent is then retained in the coronary vessel, which keeps the coronary vessel patent. So this was used initially, this was only a plain metallic stent, but with the metallic stent also, in-stent restenosis was a major problem. So they introduced something called as drug-eluting stents. So this coronary stent actually used sirolimus, which has anti-inflammatory and anti-fibrotic properties. This sirolimus, when used in the metallic stent, helped to keep the in-stent restenosis to a very minimal, and now is very successfully used in the cardiac vessels. So we thought, let us try and use this concept in the nasolacrimal system. So hypothesis was that balloon dacroplasty for acquired complete nasolacrimal duct obstruction using traditional balloons is already been tried, but the mean success rate across literature is only 37%. But can we use a drug-eluting coronary stent in the nasolacrimal duct, which is permanently kept inside the nasolacrimal duct, in order to keep the nasolacrimal system dilated as an alternative to a traditional dacrocystorhinostomy? Now, before we can actually go ahead and use a coronary drug-eluting stent, we should know that we have already established the safety and the efficacy of coronary balloons in the nasolacrimal system. In the congenital nasolacrimal duct, we have used a 2.75 millimeter balloon with very successful outcomes. Now, the advantage of these coronary balloons are it is available in various diameters and lengths. So we can also use it in cases with puncta, where we've used a 1.5 millimeter coronary balloon, or in cases with revision endo-DCRs, where we've used a 4 mm coronary balloon catheter. So over the last 5 years, we've already established that coronary balloons are very, very safe, and it can be used in the lacrimal system without any issues. It is cost efficient. That is, it is 1/4 the cost of the traditional lacrimal balloons which are available, and they are safe and effective. So now that we know that these can be used, let us try using the drug-eluting coronary stents. But can we directly use them in vivo? No. So we went ahead and we did a pilot study in 5 lacrimal systems of 4 cadavers. So let us look at the picture A. Now this stent material is a cobalt chromium alloy, which is mounted on a semi-compliant polyamide balloon, which was already tried on lacrimal systems in vivo. So we know that the balloons are at least compliant. Now the strut thickness is 68 microns and the width is 78 microns, and the outer diameter of the catheter shaft that we will be using is 0.8 millimeters. This is important because it has to traverse all through the puncta till the nasolacrimal system. The nominal inflation pressure is about 11 bars and the rate burst pressure is 16 bars. This is important because we cannot exceed 16 bar pressure, because if we exceed that, there is a chance that the balloon may burst, right? And this is coated with sirolimus. Now, according to the size and the length, the diameter and the length of the balloon, the amount of sirolimus coating will vary. So for a normal lacrimal system, a 2 into 8 mm balloon or a 2 into 12 mm balloon should be enough. So that has approximately 100 to 150 micrograms of sirolimus coating on it. Another important thing is this is MR conditional. So you can go ahead and do MRI safely even with these stents in situ, right? So the technique was, first you have to do probing under endoscopic guidance to dislodge the fibrous tissue in the nasolacrimal system. Then go ahead with a plain balloon dacroplasty using a 2.75 mm balloon. Now, why is that done? So that the nasolacrimal system is dilated. And then we use these coronary stents mounted on balloon catheter. And this is also done under endoscopic guidance. So look at the picture C over here. You can actually see this is the metallic part is the stent, and it is about 0.5 meters short on the balloon, millimeters short on the balloon. Now it is positioned in such a way that the stent is actually not visible. Only the tip of the catheter is visible, and the stent is actually inside the distal end of the nasolacrimal duct. Now, after you've placed it in such a way, you inflate the balloon. Now we saw that the burst pressure was about 15 atmospheres, and the nominal pressure was about 8 atmospheres. About 10 atmospheres. So we inflate the balloon with a pressure more than 10, but less than 15. So we chose 12 atmospheres of pressure because that is what we've been doing routinely with the coronary angioplasty balloons. Now, once you inflate the balloon to 12 atmospheres of pressure, the stent will expand and it will spring into a locked position. Now, once it is locked, then you deflate the balloon and you completely withdraw the delivery system. So once you withdraw the delivery system, here you see that this is the plain balloon and the stent is actually inside the nasolacrimal system and it has not really come out of it. And then we used a dacryoendoscope to go in and visualize the position of the nasolacrimal of the stent in the nasolacrimal system. And we saw that it was in place. Now, to confirm whether it is really safe, we went ahead and dissected these cadavers to check the position of the NLD. So now here, if you see, this is the nasolacrimal duct. This is the opening of, this is the sac duct junction. So the position macroscopically was confirmed that it is nicely placed in the nasolacrimal duct. Now we introduced the dacryoendoscope inside this system to see that whether it is reaching the distal end of the NLD, and it was clearly reaching the distal end. We also, when we introduced the endoscope within this stent, we saw that the NLD mucosa was uniformly dilated in this and uniformly distributed in the space between the stent rings, and there was no recoil that was noticed. Now, what we did was we reflected this nasolacrimal system from the bony nasolacrimal duct to see that because the stent is in place and we really dilated it to a large extent, did it cause any tear or crack in the bony nasolacrimal duct or in the mucosal component of the nasolacrimal duct? But we saw that there were no cracks or fractures of the bony NLD, and the outer mucosa of the nasolacrimal duct was smooth, right? The other thing that we wanted to know was whether it will slip into the nose. So we used a forceps and we tried to push the stent inside into the nose, and we looked through the endoscope in the inferior meatus, and yes, it was resistant. It did not come into the cavity. However, when we tried to withdraw it proximally, that is through the sac duct junction, it easily came out. So yes, if in case there is an issue and if we have to go ahead, do a DCR or something at a later date and we need to remove the stent, it is easy to retrieve it from the sac duct junction. So these were a few safety features that we evaluated. But however, this was a cadaveric study with a very small sample size. There is a possibility of false passage and failure to completely recanalize the tough fibrous part of the NLD that we already know. And we do not know the in vivo effects on the NLD mucosa and what effects will it have on long term. However, it does appear very promising. It does not allow the raw surfaces of the nasolacrimal duct to come in contact with each other, and therefore will actually prevent refibrosis and restenosis. And therefore, theoretically, it will prevent reobstruction. But we do need in vivo studies before we can really take this a long way into eliminating DCR. Thank you.
Thank you, Nandini, for this illuminating talk and sharing your preliminary study outcomes about this interesting new development in the field of dacryology. We are now joined by Dr. Saurabh Kamal, who is one of the panelists for this session. He is a very dear friend, actually a teacher of mine, immediate senior during fellowship, and again a proponent of dacryology, one of first Dr. Javed Ali's students. He practices now at iHub Center in Faridabad. Dr. Saurabh, do you have any comments regarding lacrimal duct recanalization or any of the cases that Dr. Manpreet and Nupur showed? I hope Saurabh is...
Yeah. Hello. Yeah, am I audible?
Yes, yes.
Yeah. Hi, Adit. Thank you. Yeah, I would like to comment on diverticular. Like it's, the Nupur has shown that it can be, it is a very, rare thing. But more than that, I think it is the under diagnosis of the thing. I especially come across one of the few cases in like revision cases of even endoscopic DCR, and even in the post probing, if like myself have done the endoscopic probing for a child of CNLDO, that shows the persistent watering. So there was a one case I remember that there was a ostium, a small ostium inferior, and on top of that there was a. Initially I thought that the ostium is malpositioned, has been primary surgeon inferiorly, but there was a large diverticular there. So these things have to be, they are very important, kept in mind. Even in post probing CNLDO, some patients you feel that it is patent syringing endoscopically simple or whatever complex you have managed the case, but they show some kind of a functional, maybe because of the diverticulitis or whatever that. So in that, the conservative treatment I have tried in 2 cases. I thought that could be a diverticula because we had not imaged that, and it was just a simple probing and no DCR done. So I could not have identified it even like during the probing itself. So it's a very important thing to be kept in mind even in like persistent post probing cases or in the revision cases or the failure of the primary surgery. That's all. Regarding, I think, recanalization, I don't have any comments. Nandini, she has described, looks very promising. But Nandini, any cases you have done on human till now?
Not
Anything?
yet. Not yet.
Not yet.
We
Okay.
we have the stents in place, and we will be starting the in-human trials soon. But it's very difficult to get IRB approval and the consent to take such experimental procedures on humans. So we are still struggling at that level. And once we are through that, once we cross that barrier, I think we will go ahead and do in vivo trials.
Yeah. Okay.
Thank you for your comments. I have one question for Dr. Manpreet. Since it's been attended by a broader group of audience, will it be useful to enumerate cases, especially which we think we want to explore? So what cases would be ideal for imaging in cases of suspected lacrimal mucocele? Like what cases or what signs give way that you need to image this patient before exploring or going ahead for a DCR?
Adit, you just read my mind actually. I was going to ask this question to Saurabh that personally, what I feel, in which case imaging should be done. So
Correct.
one of and straightforward cases like second case which I showed, she was having particular history, typical history basically, how to go ahead with imaging in such cases, and in which case. If there is a hard mass, okay, you can get imaging done. If there is trauma case, we usually get traumatic NLDOs that should be imaged, or any failure cases or probably repeat cases. Then otherwise, in a primary case, when to go ahead with imaging, if Saurabh can just enlighten upon that.
Primary cases is mostly when you suspect it preoperatively, like a swelling extending above the medial canthal tendon, a mucocele which is or whatever swelling is not lying primarily in the lacrimal sac fossa, maybe anterior to it over the anterior lacrimal crest. Syringing is patent. If you have symptoms of watering and you see that syringing is patent, or any history of any nasal bleeding or hemolacrimia, or any
Yeah,
dystopia,
thinkable, all
proptosis is
thinkable
there.
causes. Yes. And
Dystopia,
Saurabh, just a
proptosis is
quick
there.
question that do you perform irrigation even after Roplas is positive?
Irrigation after Roplas.
Yeah.
Yeah, I do sometimes when
What
it is
cases?
not that, if it is not frankly positive, there is
Okay.
no discharge, means just you can say a mini Roplas only. If there is a frank Roplas, I usually don't do. Anything your experience on that?
Yeah, where Adit shared one idea with me, I think couple of months back, about cone beam CT, and we are planning a thesis on that to expose the patients minimally to the radiations, and we can expand the group in which we can image the nasolacrimal system better.
Thank you so much. Dr. Reena Sethi, who was the other panelist, could not join us because she's in a simultaneous session. Now let's move on. We are 10 minutes behind time. So thank you, Nandini, and thank you all the speakers and panelists of the lacrimal session. Let's move on to the aesthetics session, which will be mainly moderated by Prerna. Let us just see how we can now progress with this.
Now, more than ever before, oculoplasty surgeons are here to conquer periocular aesthetics. The cornerstone of periocular aesthetics obviously is blepharoplasty, but we would like to start off with Dr. Rituja Thomas, who is a fellow from Narayan Netralaya, and she works in Delhi in a dynamic team with Dr. Grover. So she'll be talking about challenging case scenarios in congenital ptosis. Following which, we have a celebrated speaker from the US who will be customizing blepharoplasty and giving us some pearls on how to get the best possible outcome for our patients. Over to you, Rituja.
Thank you, Dr. Prerna. And I thank the Arunodaya Deseret team for having me on board with such an esteemed set of speakers and panel. So without wasting any time, I would just go ahead and start off with my presentation. So I'll be talking about some challenging case scenarios. It's visible, right?
Yes, your slides are visible. You can go ahead. So
some case scenarios that is which we find a little difficult to treat, or which there may be multiple treatment options. So Marcus Gunn jaw winking ptosis, third nerve palsy, monocular elevation deficit, congenital fibrosis of extraocular muscles, and blepharophimosis. So these are the ones which I felt are most challenging and which would lead to a fruitful discussion. So in Marcus Gunn jaw winking ptosis, what we normally see is that with the jaw movements, there is a synkinetic movement of the eyelid, mainly because of the abnormal connections between the motor fibers of the trigeminal nerve as well as the oculomotor nerve. So to treat this, normally what we would do is make sure that we disinsert the levator muscle. Now, in case you haven't been able to counsel a patient, that even for a mild case of Marcus Gunn jaw winking, that this we need to do a little more extensive procedure than what they initially predicted. It's important to explain to the patient that their Marcus Gunn jaw winking would actually worsen, even if it was mild, if we did simply a levator resection. So ideally, what we need to go in and do is make sure that we disinsert the levator completely, cut the horns, and then go ahead and do our routine silastic sling. Now, this gives a very good outcome. The jaw winking is effectively abolished. However, there is some lid lag on down gaze, which is unacceptable to some patients. So in case they are willing, you can sort of counsel for a bilateral fascial lata sling along with a levator disinsertion. However, this would require extensive counseling to make sure that the patient agrees that even the normal eye has to be operated upon. And not only does the jaw winking get abolished in this case, you can also get a symmetric symmetric down gaze appearance. Now, in third nerve palsy and monocular elevation deficit, this is a patient who was operated for the squint in the third nerve palsy, but you can see this upshoot of the eyelid on adduction. And this is known as the pseudo Van Graaf sign. So even in this situation, you need to sort of disinsert the levator whenever you're correcting and doing a frontalis suspension. However, you don't correct fully as you would in Marcus gun. You would undercorrect a little bit to account for not only the limitation of elevation, but also the poor bells that might be there. So this is another situation which has to be tackled based on a case-by-case basis, of course. Now with monocular elevation deficit, of course, when you do a cover test, you will see exactly how much correction you need. That is the pseudotosis component sort of goes away. And basically the elevation limitation is what has to be tackled first. So of course, you would get your squint surgeon involved. You would make sure that the up gaze restriction is sort of corrected before you go in and do your ptosis correction. So if there is a superior rectus palsy, you would have a free force duction test and a NAPS procedure wherein you transpose the lateral rectus and the medial rectus towards the superior rectus would do well, or you can do a superior rectus recession. Or if you have a restricted FDT, an inferior rectus recession would be required, after which you can go in and do your ptosis correction as required based on the level that the lid comes to after the ptosis, after the squint surgery. So you can either do your levator resection or a frontalis suspension based on the severity of the ptosis. Now, coming to congenital fibrosis of extraocular muscles, I'm just sharing this quick case for wherein this girl had a severe limitation of elevation as well as abduction and adduction. She had undergone some amount of squint surgery, but she needed multiple squint surgeries to try and align her eyes, because they keep getting worse as well. It's not progressive, of course, but it keeps getting worse because they may have some amount of amblyopia as well. Now, these patients, they sort of need very large recessions and some amount of resection to align them. And again, after the squint surgery is done, we can go ahead and do a ptosis surgery, again, very conservative, to make sure that they don't have too much of lag ophthalmos, because they would have a poor and restricted elevation. So this could cause some exposure keratopathy. So we would, again, very conservatively treat these patients. The last thing is blepharophimosis, which has not only ptosis, but multiple other issues. And I found that sort of correcting the medial canthus kind of gives you a little bit more scope to correct the eyelid as well. So making sure that you do a nice Y to V plasty before going in and doing your ptosis correction after 4 to 6 months sort of helps you get some space in the eyelid to actually lift the eyelid. They have severe ptosis, usually a very poor levator function. So we prefer to do a fascia lata sling because it's a bilateral presentation most commonly. We would do the Crawford double triangle technique. And the usual way in which we do a fascia lata sling with a small incision is ideally preferred. So in these conditions, what we aim towards is to sort of reduce that frontalis overaction and to give them an acceptable lid fold. You may not get as good a correction as you would get in normal patients who don't have blepharophimosis, who would get very good results such as these. And some issues that you may face most commonly is undercorrection. However, we rarely have overcorrection with a fascia lata sling. So that's all for my talk. And I found that blepharophimosis children, they sort of gain a lot of confidence after getting some sort of normal kind of appearance. And I wish everyone a happy World Sight Day. Thank you.
Thank you, Rituja. I think this photo is from your OR today.
Today, yes.
It came on social media before it came here, so I caught you there. Anyways, so without much delay, because our next speaker is speaking from the US, I would like to invite Deepak Ramesh, a close friend of mine, actually my co-fellow at UCLA. We trained together. And he runs his own private practice at Somerset in New Jersey, which is called a Center for Eye and Face. And he's also an attending at the Wills Eye Hospital, which every one of us know. And he's going to be enlightening us about customizing blepharoplasty surgery and giving us pearls regarding how to manage blepharoplasties and different situations in blepharoplasties. Over to you, Deepak.
Well, thank you, Adit and Prerna, for inviting me. And it's good to see some friendly faces in the speakers gallery here. It's good to talk with everyone. So Adit asked me to talk about customizing blepharoplasty. I'm going to focus on kind of all of the peri-blepharoplasty adjunctive things that we can do apart from the actual skin removal, because I think that's really where you can customize the surgery to tailor to the patient. So I think when I think about, and I'm going to mainly talk about upper blepharoplasty here because lower blepharoplasty is its own complicated subject. So with upper blepharoplasty, I think the main question that I like to ask myself is, does the patient have ptosis? Do they have extra skin, dermatochlesis, or do they have brow ptosis, or what combination of these three things? So, you know, obviously when patients age, they get a variety of different conditions, including the eyelid ptosis, brow ptosis, the skin excess, but also skin quality differences, and then the underlying volume itself. Is the fat atrophic? Is the fat prolapsed? And how do we address these to tailor the right result for each patient? So to talk about ptosis first, we'll just define some brief terms. We have MRD1, MRD2, which is the eyelid to the center of the pupil, and then we have tarsal show. Some people call it the eyelid platform. I think this is a really important measure because even though the patients don't specifically notice it, that's really what they're looking at when they're looking for symmetry. So all of these components matter, and we can tackle each of these components separately when we're trying to customize our blepharoplasty. One of the reasons why I really like to start with ptosis is because if you do a ptosis surgery and you skip the blepharoplasty, the patient will still be reasonably happy. So this is the patient from early on in my fellowship days. I did a ptosis repair. I did not touch his upper lid skin. His eyes are more open. He sees better. His result aesthetically, it's somewhat better, and he's happy. He's not miserable. This patient, again, from early on in fellowship, he really needs ptosis repair, but what I did was blepharoplasty. I took off skin, and this result is not good. This is feminizing. So I had to go back later and do his ptosis repair for him to be happy. So the two sides of that coin, ptosis repair without doing skin removal is fine. Skin removal while missing the actual ptosis really is a disaster, especially in men. So I think it's really important to first look and see, does the patient have ptosis when they come for a blepharoplasty evaluation? There's a variety of different ways you can do a ptosis repair. You can do the posterior approach, which I think is a workhorse for people who have mild ptosis. I've actually transitioned to sutureless posterior ptosis repair now. So even without the chromic gut suture here, you're just using the bipolar cautery to align the wound edges. And then there's the anterior approach where you look under the central aponeurotic fat pad and you can reattach this dehisced levator aponeurosis to the tarsal plate. This can be more powerful, but of course, as we all know, the levator muscle is a challenging muscle to work with, and you can end up with contour irregularities or undercorrections or overcorrections. So it's a mixed bag. I like to think of posterior ptosis surgery as a black box. I don't know exactly what I'm going to get out of it. I don't know how high I'm going to get, but I do know that if I do that on both sides, the eyelids end up symmetric. So I'm not really going to be too much higher or lower than I want to be. It's hard to mess someone up with posterior ptosis surgery. Whereas if they have a really significant asymmetry, or if the eyelid is really low below the pupil and you can just see the dehisced levator, then I think anterior ptosis surgery is better. But like I said, I think my personal revision rate for anterior ptosis surgery is about 20-25%, where I have to touch up an eyelid. And I don't think that's going to change in my lifetime, because every 10-20 cases I have where I think I'm great at the surgery, then I have 1 or 2 in a row where I have to go back and touch it up once or twice. So it's just a challenging muscle. There's central CNS processing and proprioception and all these things that affect how the levator muscle works. So it's a difficult muscle to operate on, as you all well know. But I think ptosis surgery in general, whether you do it anterior or posterior, is the best adjunct to blepharoplasty in my practice. So this is the patient who had upper and lower blepharoplasty. She doesn't have a lot of ptosis. She didn't come complaining about her ptosis, but just raising her eyelid that extra 1 to 2 millimeters really helps brighten the eyes. It helps freshen up the look, and it helps them really look less tired. So Patients don't complain about this ptosis. I don't even tell them I'm fixing their ptosis. I tell them I'm going to do your upper lid. But if you do it in conjunction with the skin removal, it really does make a huge difference. Again, this is another aesthetic case, upper and lower lid blepharoplasty, but I did a posterior approach ptosis surgery, Mueller's muscle conjunctival resection, and I think just that extra 1.5 millimeters of lift really makes a world of difference. So nowadays, in blepharoplasty in patients over age 50 or 60, almost all of them have this 1 to 2 millimeter of ptosis where it's not really affecting the vision, but it is making them look tired. And I think just that little bit of ptosis elevation that the Mueller's muscle conjunctival resection provides is safe, it's low-hanging fruit, you're not going to mess them up or give them a profound asymmetry, and it really gives them a much nicer blepharoplasty result. So I think this is one great way to start customizing your blepharoplasty surgery to the patient. This is a patient who had blepharoplasty, and they actually had a little bit of levator aponeurosis damage. So you can see that her crease has slipped on one side. So the treatment for this actually is to do a levator advancement and reform the crease. So again, ptosis surgery can be a powerful adjunct to the blepharoplasty, not just for the lid position, but also for the crease position. So she actually came and said, can you redo my blepharoplasty and take out skin? I still look puffy on my right upper eyelid. But the treatment is not to take out more skin. The treatment is to fixate that pre-tarsal skin back where it should be and form a hard crease. So again, you really have to be comfortable addressing the levator muscle and its attachments to the surrounding structures to really tailor the crease formation. Because again, that tarsal platform is what patients really notice, the height from the eyelashes up to the lid crease. So you really have to be precise about how you define that. Brow ptosis is the next most common adjunct to ptosis surgery in my practice. So any patient who has lateral hooding or who has a little taper of their eyelid platform as they go from medial to lateral is a candidate for brow ptosis repair. I love showing patients this photo because they always ask me, I came for blepharoplasty, why are you telling me I need a brow lift? And I did this woman's upper and lower eyelids. Her right eye looks fantastic because her right eyebrow is in a normal position. Her left eyebrow is ptotic, so you can see after blepharoplasty, it actually even makes the lateral hooding worse because the more skin you take out without resuspending the brow, the lower the brow ends up being. Now, she was happy. She didn't want to do the brow, but some patients will be very unhappy with this result. And if you don't counsel them preoperatively and say, your brow is drooping, if I don't touch it, you're going to be heavier on that side, then they're going to be very disappointed. So it really, really is important. The point of brow lifting surgery is not to change the shape of the brow so much as it is to make your blepharoplasty better. It's to make your eyelid symmetric. So again, lateral fullness, so any skin or heaviness past the corner of the eye, and uneven tarsal show, meaning that if you have more tarsal platform medially than you do laterally, these are patients who have brow ptosis. And these two patients, I only did blepharoplasty. I did not do any brow repair. And you can see they still retain their lateral fullness, or they still retain that little taper of the eyelid platform as you go from medial to lateral. So if patients want to put eyeliner or eyeshadow on the eyelashes out to the very last eyelash, and they want to wing it up right here, then you have to do the brow surgery. Otherwise, they're not going to get that lateral clearance that they want. And the more skin you try to take out of here laterally with the blepharoplasty incision, the worse the brow ptosis is going to be, and the worse you're going to make the problem. So you really have to suspend it from above. There's a variety of ways to do brow lifting. You can do a direct brow lift, which is very simple. You can do this in men who have bushy eyebrows or deep rhytids, and they do really well. Or you can do an endoscopic lift, which I'm not going to show you the video, but essentially endoscopically you release the periosteum and the thickenings essentially in the area that you want. I usually release them from the tragus out to the supraorbital notch because really people need that temporal and lateral lift, and I fixate with bone tunnels here and to the deep temporalis fascia laterally. And when you do a brow lift in conjunction with the blepharoplasty, you clear the lateral hooding, and you give the patient an even tarsal platform from the medial edge out to the lateral edge. So if you want this to be the same and you want to customize that to what the patient wants, you have to lift their brow at the appropriate height, and you have to lift it in the direction that you want. So what I mean by that is some people have more medial brow ptosis on one side and some people have predominantly lateral ptosis. So how you lift the brow For example, this patient is symmetrically ptotic, really in the outer 50% of her brow. So I lifted her, I released her periosteum from the supraorbital notch out here on both sides, and then I fixated with bone tunnels on both sides. Some patients have asymmetry. So she came for blepharoplasty, and I only did brow lift for her. And I did a brow lift more on the right side than the left side because she has asymmetric right brow ptosis. So I only did bone tunnel fixation on the right side. I did temporalis fixation on both sides. So this side had 2 incisions, this side only had 1 incision. So the periosteal release in this side was from the supraorbital nerve to the tragus. On this side, it was really just in that lateral outer 1/3 of the brow at the arcus marginalis. So again, the brow lifting procedure is very customizable. How much you release the tissue along the superior orbital rim is how high and what shape the brow is going to be. So if you release it more here, this part is going to come up more. If you release it all the way across, then the whole brow is going to come up. So not every patient needs tissue medial to the supraorbital notch released. In fact, I would say it's less than 10% of patients who need any release in the glabella. This is an area that's best treated with botulinum toxin. So this is probably the last patient, that I treated with medial brow depression and elevation. What I did was I lifted the brow here, bone tunnel here, temporal fixation here, temporal fixation only here. I cut the corrugator on this side, I cut the frontalis muscle on this side, and then I did a bunch of Botox. And this is not a face that she's making on the left, it's just how her frontalis muscle activation is. So you can see that after adjusting those things, without touching the eyelid at all, you really get much better eyelid symmetry. So the upper eyelid and the eyebrow really are 2 sides of the same coin. If you touch one, it's going to affect the other. So really look at the brow when you're trying to decide, what do I want to do for this patient's upper blepharoplasty? The last thing I'll say about brow lift is that, again, the shape of the brow can be changed, or you can leave it the same. So this patient was very precise about saying, I always had these sad little puppy dog eyebrows. My lateral eyebrow was always lower than the medial one, but she still needed elevation to get that tarsal platform to be symmetric. She still has brow ptosis. So if I did the same brow lift that I did for the other patients, then she would have had an arch here and it would have changed the shape of her brow. So by minimizing the temporal elevation and focusing a little bit more on the central elevation, I was able to retain the downward contour of her brow while still giving her the symmetric tarsal platform that she wants. So respect the natural brow shape and really focus your release on how the shape you want it to be is and how much you want to raise the brow one side versus the other. So that's a really great way to customize the upper blepharoplasty result by really tailoring the brow surgery to what the patient needs and what their old photo looks like. And then the last thing we'll talk about is the skin itself. So you can do a very conservative skin resection. So I like to show patients these 3 pictures when I ask them how high or how much skin they want me to remove. This is a very conservative result. They have a 5-6 millimeter crease, just enough to have space to put some eyeliner. This is an average result, so probably 7-8 millimeter crease, a little bit more eyelid platform, and this is a very aggressive result. So 10-12 millimeter crease, a lot of space here. Most people fall right here in the middle. The next most common is to have a very conservative result, especially in the younger patients. And then very, very few patients nowadays want this kind of aggressive result. But by showing them those 3 pictures, you can almost immediately tell on their face, they have a reaction. Some people will say, oh, it's like you almost didn't do anything at all. And then they look at this and they say, oh, that's great. Or the other kind of patient will look at this photo and say, oh my gosh, that's way too much. I can't imagine having that surgery for me. So just by looking at this photo, you can tell what they want and you can decide how aggressive you want to be with the skin and the fat removal. And sometimes it's not just about fat removal, you also need to add fat back to the relevant area. So patients who have superior sulcus hollowing need fat grafting in the periorbital area. So I did her upper lower lids, I did some ptosis surgery, but I also added fat to her midface and her superior sulcus. So you can see that that actually provides a lot of aesthetic benefit for the upper lids. And in general, it's always nice to take a step back and look at the patient's face as a whole. So when they come for blepharoplasty, ask them, do they need global fat transfer? Do they have global volume loss? So this patient had upper blepharoplasty, but she also had fat grafting to the temples, the midface, the tear trough, and the marionette lines. And overall, her face now has become more apple-shaped and rounder. The volume is up at her mid-face where it should be instead of down here, just from adding that requisite volume. And of course, you can also combine your upper blepharoplasty with various lifting procedures that overall redefine and shape the face in the shape that you want. So again, thanks Adit and Prerna for inviting me. Great to talk with everyone.
Thank you so much, Deepak. I think this was pretty much a very wholesome talk on upper eyelid blepharoplasty. In fact, I can't think of anything you could have added to this. So in the interest of time, Dr. Adit has probably decided to keep his talk for the end if we have time. I have a couple of questions for you. So you spoke about fat grafting. I just wanted to know, is that your preferred choice of method for the orbitoglobular groove? So we see orbitoglobular groove very often, sometimes more so in the Asian kind of profile when we do blepharoplasties. Or do you prefer a fat transposition from the upper eyelid itself?
I've almost eliminated fat transposition from my practice. I'm doing 99% fat grafting in patients. There's several reasons. One is in the Asian type patient who has mid-face hypoplasia, they need more fat sometimes than the donor site can provide, and they need it not just inferiorly, but they often need it laterally or at different places along the mid-face. So the repositioned fat is tethered to where it is in the orbit, and you're dependent on how much there is. So oftentimes if I reposition, then I need to add grafted fat anyway. So I'm just doing an unnecessary dissection. So at that point, I decided just to trim the fat and then add the fat that I wanted where I wanted. And that seems to be more predictable in my hands. I know a lot of people still do repositioning, and there's a thought that, well, if you have native blood supply and native fat, that gives you a better result. I don't think that it's an issue of native fat versus grafted fat. I think it's an issue of how you treat the fat when you do process it. So I think if you avoid centrifuging, if you avoid time outside the body, and you don't use a very sharp cannula, if you use a blunt cannula to harvest, you can preserve the fat cells alive. And I usually spend maybe 15 minutes off the field before it's re-injected into the patient. And that seems to give me a pretty good survival rate at 1 to 2 years, probably 70-80% volume survival compared to 30-35%, which is what was reported in the 90s when fat grafting used to be done.
For the upper eyelid, do you open the upper eyelid up when you want to fill the sulcus, or you use the microcannula to fill the upper eyelid?
The microcannula. The microcannula. I know some people in really, really recalcitrant cases will take a dermis fat graft and stitch it onto the bone of the superior orbital rim. I think, if someone's like 80 or 90, that might be a good option if they don't have a lot of surrounding volume support to support the grafted fat.
Hmm.
And I know you and I tried lifting the central fat pad up to the brow. I find that that's really dependent on how much you have. So if someone really has a lot of atrophy in the superior sulcus, they're just not going to have enough to make a meaningful difference in that area.
Perfect. I think that makes sense. So it probably sometimes just adds a little bit two-dimensionally, but it does not give enough volume for the three-dimensional contour of the fullness for the upper eyelid. So maybe 1 or 2 more questions, and then maybe we can have Dr. Milind give us his comments on the aesthetics session. So Deepak, I just wanted to know, you were were correct about it, that it's very difficult. You can seldom be wrong with the Muller's muscle resection when it comes to cosmetic upper eyelid blepharoplasty. Occasionally in volume deficit patients, do you see that there is sometimes, though they say that the pre-aponeurotic fat pad slides, or there is some mechanism where, there is a little bit of volume filling even after the Muller's resection, but do you see some amount of orbital rim showing in, very rare instances where you've done the Muller's muscle resection and sometimes the sulcus fullness is not up to the mark?
I'm noticing some superior sulcus hollowing, but I'm not sure if it's from the ptosis repair or from the lower blepharoplasty, because I feel like if you take out some of the inferior orbital fat, which is what the lower blepharoplasty fat is, I think the globe might actually come down a little bit and the fat repositions. So it's a great question, and I just have been thinking about it in the last 2 or 3 months. I'm not sure which of the procedures it's related to. I think it's probably the lower bleph.
And probably my last question to you would be a little partial, but I know that you do a bit of periocular lasers, or I'm not sure, maybe you used to do, and it's more often done for the lower eyelids, but occasionally do you also consider the erbium YAG or the carbon dioxide for the upper eyelid as an adjunct to your blepharoplasties?
That's a great question. There are patients who have lash ptosis, and after you do the blepharoplasty, if you apply one line of laser instead of the usual 2 or 3 lines just above the lashes, or you can apply TCA 35% or 20% or something, they get a little bit of contracture, and that does bring out the lash ptosis a little bit. So that's a low risk way to address that.
Thank you so much. Adit, would you like to add
Any comments from Dr. Milind, Rutuja, or any of the other panelists present here?
Hi, it's always a pleasure to hear Deepak. Deepak, that was a wonderful talk. Just one quick question for Deepak. I always struggle with these Indian patients who have a lot of pudding laterally, which is sometimes beyond the canthus. So in these patients, I cannot do that high upper brow blepharoplasty, so to speak, and I cannot extend the incision beyond the crease either. So I'm always stuck with giving them something which is not going to be liked, I know. So do you face these situations, and what do you do? Oh, Deepak, can you all hear him?
Oh, sorry, I think I was muted. I was saying it's a tough scenario, and it's an unsolved problem, as you know. I think, one middle of the road option is to debulk some of the roof fat, the brow fat, and then do the brassiere suture. So that way, even if you're not lifting the brow, at least you are preventing it from being more tautic, and you can also kind of clear the tarsal area a little bit by just separating the brow fat from the pre-tarsal area. Imperfect solution.
And that's what we experience in India a lot. Patients are very resistant to eyebrow surgery. Usually they would be very keen about blepharoplasties, but when you talk to them about eyebrow lifts, they're like, no, that'll be too extensive for us. So we have to find...
I experience the same issue, but I frame it like this. I tell them that the point of my brow surgery is for your eyelid. So if I don't do this, your eyelid is going to be asymmetric, or you're still going to have this skin out here. And they seem to, I think if you show them the pictures of what it's going to look like if you don't do the brow lift, then they really get a good sense for, okay, this is why I need to do it. But, it is sometimes some people just have a resistance to doing anything surgical, so.
I just wanted to ask, you're not suturing in MMCR, you're not suturing. So how do you make sure that it opposes, or you don't get a tarsal buckling or something?
I have switched to sutureless MMCR only for 3 months. Before that, I used to use the 6 Cormicut suture. I am in my trial period with that, but I've been happy with the results so far. I think there are probably about 500 to 600 published cases now where people have used the bipolar to oppose the edges. And I make sure to do that at the end of my upper eyelid procedure so that I'm not going back and re-manipulating the upper eyelid. I'm moving on to some other area. So the short answer is I don't really know personally, but I feel like other people have gotten enough good results. And in my short time scale with the procedure, it seems to be working, that I haven't really had too many issues.
Okay, thank you so much, Deepak. I know that you have to rush in for your clinic as you have scheduled your appointments. Thank you so much. It was a pleasure having you speak on upper eyelid blepharoplasty. And with this, I would ask everyone to move on to the next session where we speak about thyroid eye disease, which has always been a mystery for every one of us, although we are proceeding now from being carpenters to understanding more of immunologics about the disease. But for this session, we again have, I have my colleague and a very dear friend, Dr. Hamza Mushtaq, who joins us from Cape Town, South Africa. He is a full-time faculty at the Groote Schuur Eye Hospital in Cape Town and also runs a small private practice at the UCT Hospital in Cape Town. He also trained at UCLA, and I passed the baton on to him, and we apparently also passed on my apartment to him when he joined UCLA. He'll be speaking about his two challenging case scenarios, following which we will have Dr. Milind Naik. He'll need no introduction, but Prerna will be introducing him. And we have Raghuraj Hegde is a close friend of mine from Bangalore, and Pallavi, who's joining us from Ahmedabad, who will be taking forth the discussions in this session. So over to you, Hamza. I hope you can hear us. Is Hamza there? He has joined us, but I think he's not online. I'll just get in touch with him. I think Dr. Milind can then proceed with his talk. Prerna, can you I'll just call Hamza.
So Dr. Milind Naik is literally somebody who is handheld over half of the oculoplastic surgeons through learning oculoplasty, and his body of work in thyroid eye disease is it's definitely proportional to all the wisdom that he has gained over the years out of his experience in thyroid eye disease. I don't think I would be wrong in mentioning that he probably has the largest volume of experience with respect to this disease. And we are definitely looking forward to learning a lot more from Dr. Milind Naik. He's a consultant in oculoplastics department in Orbit at LV Prasad Eye Institute, Hyderabad. Dr. Milind, can you enlighten us a little bit more about the complexities of this condition?
Yeah, hi, Prerna. Hi, Adit. Thank you so much for making me a part of this wonderful program. And I saw the galaxy of speakers you guys have brought in here from all specialities. Really feel honored to be a part of a component of it with friends here and colleagues. So initially, a thank you to all the teachers over the years from whom I've learned, all the alumni who've collected data over the years because of which I can speak and publish today. And also hello to Hamza, whom I met very recently, a week ago, in fact, in South Africa. And very impressed with his progress and work, and I hope to hear him very soon. So quickly, I'll go through the pearls that I've learned. So here I'm not really going to talk about theory, but how my practice has changed, looking at how things are different in the West versus what we see here and stuff like that. So initially starting with the myths, a lot of patients and unfortunately a lot of endocrinologists and ophthalmologists are not aware of the fact that this disease has a very fixed amount of immunological activity, which is the active phase of the disease. And most of your immunomodulators work only during this phase. There are far too many patients I see who are in the inactive phase, time-wise, who are still on steroids eternally. So this is something which I believe is a myth which we have to all actively discourage. So I always tell the fellows too that if your first sentence describing a thyroid patient does not tell me whether he is active or inactive, I am completely lost as to what I would advise. So that's the first thing I need to know about a thyroid patient. And all the more it is a clinical disease, I don't need a scan, measurements, or a CT to diagnose this. The clinical findings are pretty obvious. And there are only a couple of situations where you might want a CT for the diagnosis purpose. I would say unilateral cases where I suspect something else, I would do a CT. Most of the other CT requirement is for planning surgery or for confirming the fact that the apex is compressed and corroborating it with your clinical findings. And I always compare the active disease with pregnancy. And I keep telling the fellows that throughout this active phase, the patients will come, they will complain. No matter what you do, their complaints will not reduce. But your primary job is to just do watchful observation until the final time. And over the years, I have realized that there are very few things that you can do during active phase which will actually change the course of this disease. And steroids, in my opinion, is really not one of them. So the only areas where I personally now use steroids is if there is compressive optic neuropathy or there is disfiguring inflammation. Early on in my practice, I used to use steroids for everyone who is by definition timeline-wise active, but now I don't for multiple reasons. A lot of patients also believe that the thyroid level is under control, and so the eye should reverse back. And this is something which many ophthalmologists believe. This is again one of the myths that we have to fight against. This is by far the most popular myth, that you give steroids and your eye findings will reverse. I think steroids only fast forward the active disease. They don't really change anything, but they can give tons of complications to the patient. So currently I only use this for compressive optic neuropathy as the first line of treatment, and quickly jump to decompression if it's not working. Talking about the measurements, the paradigm, most patients today that we operate on, they need cosmetic correction. So it's not being done only for vision, but it's for appearance. And apart from the standard measurements, it's very important to look at various components of the scan and understand what you can offer to the patient, because not everything is the same in a given patient. I like to know whether it's muscle disease or fat, because muscle disease in general is tough to operate. The retraction is difficult. I might need senior assistance when I do this, and all these add to the final result. So retraction is not an easy thing in muscle disease. Plus, you know that strabismus is more likely to be pre-existing or common post-surgery. Every patient's bone is different, so what I'm going to offer with two-wall decompression will vary based on the CT findings. So I generally don't talk to patients about how many walls and what surgery and what cost unless I see the scan. So I tell them, first you decide whether you want surgery or not. If you've decided, then we'll do a scan and then we'll talk about how many walls. Another clinical discussion which I learned over time is important to do is to divide these patients into these three categories. So one is a unilateral case where the other eye is absolutely normal. These patients, it's important that you skip the floor as an option, because that can create a vertical asymmetry when you operate them. Probably the easiest ones are the bilaterally symmetrical one eye surgery followed by the other. And another tricky, challenging situation is a bilateral but asymmetric disease like the one on the right. So here, I always have a separate discussion about these with these patients about their better eye. And I ask them, how do they feel about that eye? And if they say, oh, that eye is normal, then I know that I have to just operate on her right eye and match it to the left eye. But if they say that, oh, both are bulging, but the right one is more, then I know that I have to correct both, and that too in an asymmetric manner. So this is something which you have to pre-decide, because that decides how far you're going to take back the worse eye, which will be usually your first surgery. Another discussion I do with patients these days is whether you really want to go through the whole complications and problems of decompression, or you just want to take care of the eyelid and make your appearance more symmetrical. And I'm surprised to know how many patients just choose to stick to the eyelid when they hear about diplopia and possible strabismus surgery added and all the sensation-related issues around the eye. And this is a good choice for many patients who have mild to moderate bilaterally symmetrical proptosis, where it's not really going to look as bad as you can see in this lady who just preferred a muellerectomy on the left. Navigation I use not very frequently, but whenever I use it, I find it more robust for the medial wall. Talking about approaches, lateral wall, I choose the eyelid crease, and that gives me a very good exposure superolaterally. For the lower eyelid, use post-septal transconjunctival incision. It again takes you onto the floor in a couple of seconds, actually less than a minute. And medial wall, of course, is transcaruncular. I prefer to split the caruncle rather than go retrocaruncular because it's easier for me to approximate it absolutely perfectly radial when the surgery is over. I've done this once in my life, bilateral severe decompression via coronal approach. The patient did extremely well, but my back was not okay for a couple of days after that. And I decided not to repeat this again, at least at my age. So this is in short the preferred approaches for the three walls that we often do. And fat decompression is always a great choice for mild proptosis, one walls for a little moderate findings, and anything beyond that would require 2 or 3 wall. And I'll just skip quickly through these pictures. Come to, yeah, this is a scenario where the proptosis is so extreme that I did my best with the orbit. He still is proptosed, he's better, but he's still proptosed, and there's always a stop point for beyond which you only can distract the rest of the anatomy, bring it forward, but I just put that as my line where I draw a line and I say, okay, this is what I can achieve. Customize is, of course, choosing a particular wall to try and displace the eyeball so that we get them symmetrical. Floor is the best example to move the eyeball down to clear the inferior scleral show. On similar lines here, the lower eyelid retractor release for a high myope, not really a thyroid patient. Strabismus surgery, the two things that are worth noting is that you have to predict what the strabismus surgeon is going to do. In this case, they will recess the IR, and that will worsen your proptosis. Any recession increases the proptosis, so you have to pre-calculate that and over-decompress them so as to accommodate the strabismus surgery. And strabismus surgery also gives you lower eyelid retraction, which you have to warn the patient about. This is a surgery you almost always need to do it at a concessional rate because this is a problem created by your colleague. I'll skip the eyelid part. Just wanted to mention that extreme lateral torso is a very good solution than trying to recess the levator or release the retractors, especially for mild upper and lower eyelid retraction, as you see here. It just saves time and gives great symmetry. Otherwise, we discussed about millerectomy earlier. This is the same patient I'm showing again. And levator recession for moderate cases and full thickness blepharoptomy for severe cases. Lower eyelid retractor release can be added to most decompressions in the part 1 itself, but sometimes you may have to go in and do it separately. And it can be a good adjunct to a floor decompression to move the eyelids up. And I'm a believer of combining procedures, not only lid retraction and decom or lower eyelid retraction and decom, but also ptosis and decom, which rarely is seen in our practice. So I'll just skip the cosmetic part because we will just talk about the decompression stuff. But Prerna, I'll give it a stop here, and if there are any questions, thank you so much.
Thank you so much, Dr. Milind, for that illuminating talk. And now we have Hamza, who has joined us from Cape Town. Hamza Mushtaq is a very dear friend and a fellow at UCLA. Now he is at the Grotsure Eye Hospital in Cape Town, which is one of the busiest referral practices for oculoplastics and oncology, and also has a small private practice where he does his cosmetic work. Hamza's primary research interests have been propagating the treatment of retinoblastoma in the southern African region and developing protocols for intra-arterial and other forms of newer modalities of chemotherapy. But along with that, he also runs a very busy orbit practice, and it's our pleasure to have him here talk about his 2 challenging case scenarios of recalcitrant orbital thyroid eye disease. Over to you, Hamza.
Thanks so much, Adit, and good to see you guys again. Apologies for missing my timing. I think I'm off with the time zones, but let's start. Shall I share my screen?
Yes, please, Hamza. Once you finish your cases, we'll take all the questions and the discussions by the panelists after your talk.
Is it sharing? No.
We can't see your screens, but in the meanwhile, I'll take the privilege of introducing our panelists. We have Dr. Raguraj Hegde from Bangalore. He basically is a very prolific oculoplastic surgeon in Bangalore, mainly affiliated to Manipal Hospital and also visits a couple of more hospitals there. And then we have Pallavi Singh from Ahmedabad, who has just completed her fellowship from UCLA and is trained at AIIMS primarily, and also is trained in strabismus along with oculoplasty. So she might give us added insights about strabismus surgery in thyroid eye disease. Hamza, we still can't see your screen.
Hold on 1 second.
Anyways, I think we can, till Hamza figures out how to share his screen, we can quickly take 2 or 3 questions or comments from the panelists.
I had a question. So regarding the mullerectomy, what is the subset of patients that you use mullerectomy for? Because sometimes there's a fibrous component of that fibrosis is there in the middle lamellae and even at the conjunctival layer also. Just doing a mullerectomy, would it resolve the retraction?
Okay, hi Raghu.
Yeah.
I think you can add a mullerectomy to any component of lid retraction, irrespective of the cause, and it will drop it by 2 millimeters, just like creating a hot nurse. But primarily, upper eyelid, you can divide lid retraction into predominantly levator type and predominantly Mueller type. And that will really help you to decide which surgery you would want to do. So I added only for mild cases, which are predominantly Mueller type. So Hamza's presentation is here. Let's listen to it.
Yeah, Hamza, we can see your slides.
All right, great. Thanks for that. So I'm just going to take you through some of the challenges we've faced with a few patients with thyroid eye disease. And these are cases where these patients don't fit the protocol, and so your management is a bit sort of off the cuff. So the first case is that of a 69-year-old male of East Asian descent. History of Graves' disease, which was diagnosed 12 years ago and received a radioactive iodine 10 years ago for this. So he's currently hypothyroid altroxin, 125 micrograms daily since his radioactive iodine. So the issue with him at the moment is he developed or diagnosed with and developed primary open angle glaucoma with very poor IOP control on maximum medical therapy. He subsequently then had bilateral cataract surgery and glaucoma drainage devices. However, still ongoing elevated intraocular pressure in both eyes, despite this drainage device as well as maximum medical therapy. So he was then referred to me, presenting with several months' history of episodic red, painful eyes and deteriorating vision. So on examination, his visual acuity was count fingers at 1 meter in both eyes. He didn't have any significant exophthalmos on Hertels, as measured at 19 millimeters, but of note was severe conjunctival erythema, chemosis, and these dilated conjunctival vessels. His intraocular pressure then was 46 and 48 millimeters, respectively, right and left, and his cup to disc ratio was 0.7. There was no evidence of disc swelling. So we pulled some serology, and his TSH was within normal, but very high free T4, and his TSH receptor antibodies were also elevated. And so at this stage, we entertained a differential diagnosis of dysthyroid optic neuropathy, or possible orbital congestion with orbital hypertension and secondary glaucoma or intraocular hypertension. So we admitted him for pulsed IV methylprednisone. He was on maximal anti-glaucoma medication, including oral acetazolamide. And we asked the endocrinologist to come and have a look, and they weren't too concerned. They just adjusted his altroxin accordingly. So after 48 hours, he showed very little, very poor response to the steroids, no improvement really in his visual acuity. His intraocular pressures remained high, and his congestion hadn't really improved. At this stage, we managed to get a CT orbits for him, and you could see, enlarged recti with apical crowding. And so we then decided, given the poor response to the prednisone, that we would then take him for decompression. And I opted for a lateral wall decompression. That was the mainstay of my training during fellowship, as well as removal of fat. Then, interestingly, we readmitted him 7 days post-op. He was complaining of severe pain in his left eye with a notable decrease in his vision. And at this stage, his visual acuity was now hand movements. He had a severe chemosis on the left with conjunctival prolapse past the lid, and his IOPs had increased even more on maximum treatment. He also had bilateral microcystic corneal edema at this stage. So he was admitted by one of our residents and then given a single dose of IV methylprednisone, thinking it's post-operative inflammation. But again, his congestion and inflammation didn't improve. And on gonioscopy, open angles, no blood in Scham's canal. So at this stage, then we opted to do a medial wall decompression with removal of the posterior struct and the anterior and posterior ethmoidal air cells. And within 24 hours, his IOPs responded. It came down to 19 and 21. His conjunctival prolapse and chemosis actually settled down after 2 days. And this is the picture of him at 2 weeks follow-up with a stable IOP of 18 millimeters mercury both sides. So we asked ourselves what went wrong here and looked at some of the mechanisms of raised IOP in thyroid eye disease. And one of the suggested mechanisms is increased episcleral venous pressure from a congestive orbitopathy. The other mechanisms reported are, the fibrosis and contraction of the extraocular muscles, glycosaminoglycan deposition in the trabecular meshwork causing outflow obstruction. And then the other thing you need to consider is the use of steroids in these patients. I think that many of them are on topical steroids to treat their ocular surface inflammation, as part of their symptom management. And whether or not this patient might have had a steroid response, and we sort of plied him with more steroids during his treatment course. So the key points from this one is that the proptosis doesn't always correlate well with activity or intraorbital pressure in these patients. And you need to consider all the mechanisms of raised IOP in thyroid-associated orbitopathy. And this one, sort of made me question what the importance is of a medial apical decompression in severe congestive orbitopathy. I think this is something that's suggested by the Moorfields group, who feel that in order to alleviate the orbital congestion, you have to do a deep medial wall decompression. So take you through the second case. Is also a 60-year-old male. Initial clinical presentation with hypothyroidism, and he was diagnosed by our endocrinology team with follicular thyroid carcinoma, which he was then treated with radioactive iodine and has still receiving ongoing treatment with altroxin for that. He presented to us with a 3-week history of progressive loss of vision with red, painful eyes. At the time, symptoms of hypothyroidism with weight loss, muscle weakness, heat intolerance, and tachycardia. Of note is that he's also a heavy smoker. And in terms of ophthalmic history, previous bilateral uncomplicated cataract surgery. So this is a picture of him at presentation. His visual acuity was hand movements, proptosis measuring 26 millimeters in both eyes. his intraocular pressures were normal, but fundus exam showed disc pallor with a cup-to ratio of 0.4. And his CAS was scored as 6 out of 7. So diagnosed with sight-threatening thyroid eye disease with exposure keratopathy, corneal and scleral sort of signs of early corneal melt and scleral breakdown, and possible dysthyroid optic neuropathy. His TSH was well suppressed, but very high T4 and very elevated TSH receptor antibodies. His CT scan confirmed, enlarged muscles with apical crowding again, and possible optic nerve compression. So he was admitted for multidisciplinary management. We also opted to pulse him to try and see if that would improve his symptoms, and he also received intensive lubrication. But we had a very low threshold for decompression surgery in him. So on day 2, he then developed delirium with hallucinations, inappropriate behavior, and features of psychosis. And we asked our our physicians to come in and have a look, and they advised us to stop the methylprednisone immediately. And we also excluded other systemic causes of delirium. So at this stage, we diagnosed him with steroid-induced psychosis, probably primed by his underlying hyperthyroid state. He was treated for this with quetiapine and lorazepam, and his delirium actually settled within 48 hours of stopping the steroid. But still severe lag ophthalmos, and we were still managing this with a moisture chamber. He was actually quite reluctant to have surgery. So eventually we then convinced him, because his exposure was getting worse, and you can see on the second image at the bottom, he started to develop some scleral melt. And at this stage, we considered other possible interventions, other disease modifying or biologic agents, immunosuppressants. We, in consultation with the physicians, whether he should get rituximab or cyclophosphamide, but they felt his overall general health, they would prefer not to have given it. So eventually we convinced him that we needed to operate, and we did a bilateral lateral or medial wall decompression. Very challenging because of the scleral melt, to try and ensure that you don't cause a perforation of the globe, but the surgery went well, and he had a very good surgical response. But the issue we have for him is that whether he's going to require ongoing immune suppression as part of his disease management. Because the issue here is not just a straightforward Graves' disease. He's got underlying follicular thyroid carcinoma, and how we're not quite sure how his orbitopathy course will run, given the diagnosis. So we followed him up subsequently. So 1 week post-op, improving, and at 6 weeks post-op, you can see from our rather aggressive decompression that he's now developed esotropia. And we'll ship him off to our strabismus surgeons once he's stable. So key points here is that decompression is sometimes required in an acute state. A lot of the protocols that we use call for the use of IV methylprednisone or steroids prior to considering surgery. And we just have to be aware that it can induce delirium or steroid-induced psychosis. And we may need to consider alternate immunosuppressants in some of these patients. Thank you.
Thank you, Hamza. Those were indeed two challenging scenarios. Now we just open the session to discussion. We have a cute little attendant in this session with Raghu as well. So over to you, Raghu and Pallavi. It's your...
Yeah. Can I make a comment if that's...
Yeah. Please, it's your session now.
Thank you so much, Adit and Reena, for having us. Just to sort of reiterate what Hamza showed, in his first case, and this was, I think, a very useful tip that Dr. Millen told us at one of the cadaver courses, especially when you're starting out with decompressions. A lot of us tend to learn lateral decompressions in, fellowship. So in your head, you always tend to do, bias yourself towards lateral decompressions. But to be able to get a complete decompression, Dr. Milind had very rightly pointed out that you need very good assistance. You need good retraction and you need good equipment, which might not always be available to you in every scenario, unless it's a very sort of old setup where everything's already set up for you. So in those cases, what he suggested is that it's a better idea, at least when you're starting out, to do a medial and a lateral decompression, because medial decompressions are, I feel, are easier to perform. You don't need as much adept assistance. So I thought that was a very useful tip. And I think, as Hamza also rightly pointed out in his first case, that, we are a little resistant to do medial decompressions, but I think they're very helpful.
Yeah, that for me, no.
Yeah, no, yeah, thanks for that comment. I agree with you. I think I'm a Goldberg disciple, so he's and all we did in Los Angeles was the lateral wall, and I've had to learn to add medial to my armamentarium, especially for these challenging cases.
I actually had another question for the panel. Do you have any experience with biologics like tocilizumab or anything else, any IL-6 inhibitors for patients who have steroid-resistant orbitopathy? Because a lot of times we have these patients who've not just had 6, but also had 12 cycles, but they still have that, kind of active disease, so to say, because it's like this constant ongoing inflammation. So if anybody's had any experience with, tocilizumab or any other biologics for these cases.
So, I mean, I can start. So we manage these patients in conjunction with our endocrinologists, and we have got, a fair amount of experience with rituximab as a biological, but not not the other agents, but and a lot of these patients actually do quite well on rituximab. But I think we tend to follow the UGOGO guidelines in terms of management of these patients. And what I've started doing is that if we're going to pulse patients, I've started them. You can sort of pick up those who are going to relapse after the the 6 week course of injections. We start them on mycophenolate mofetil earlier on, and they seem to remain more stable over the period of a year with the mycophenolate mofetil. But I think the problem is that in my setting, we don't have a lot of endocrinologists or physicians experienced with managing biologicals for these patients, because they don't often know what they're monitoring, in terms of an endpoint. So.
Yeah, we also involve the immunologist at that point as well. So they are also part of the treatment. If we are, especially recently, since we've started using MMF in the treatment protocol, the endocrinologist is not very comfortable with the handling the biologicals and that. So he wants a immunologist on board. So that way it's much more rounded, and they are very good at managing these kind of cases. Mm-hmm. And also, I had one question. Basically, I think I've asked Dr. Milind also once regarding this. Like some of these orbital decompressions, especially the quiet ones, the ones you go in for a cosmetic decompression, the fat actually is fibrous. So when you actually go in and see, it's all hard, like a lardy kind of thing. So it doesn't flow out when you just make space in the bone. It really doesn't flow out. And even if you remove the fat, excise the fat also, the muscles don't move into the spaces that you've created. So you don't get the decompression that you are actually wanting to achieve in that. So in those kind of cases, what do you do? Like at some point, you can't go more. You can't go more than 3 volts. So in those kind of cases, is there any other way we can? Is there any other way we can do this? Hello, am I?
Yeah, Hamza, do you have any thoughts?
You can go for the roof if you're in Japan.
Yeah, in
No,
Hashima-san,
but even if you're in the roof, right? If the muscles don't move,
Yeah. So
like if you have,
so
I mean,
what one very pertinent point that Milind made in his talk is, as you do more and more of decompressions, when I realize it's bilateral symmetrical proptosis, I convince the patient that just get the eyelids operated, because you don't want to induce any new onset diplopia in these cosmetic patients. So I have also started becoming more conservative. If it is unilateral proptosis, cosmetic issue, then we go all out. But as you mentioned, fibrous fat is always a problem. The more you prod and more you explore within the orbit, becomes an issue. And I personally don't go beyond lateral and medial wall. In most of the cases, I rarely touch inferior wall unless there's a hypoglobus present. But I don't know how to manage these cases. Milind might have more experience.
Raghu, with the fibrous fat that you described, here's what I find, that these are the patients where on table you feel that nothing has changed.
But more decompression.
But a little later, a couple of weeks later, you do see the benefit. So if you are, then your question will be then when to stop during surgery, when do you call it as an endpoint? It's really challenging. I think I will just remove the amount of fat that I would have removed in an otherwise 2 mm proptosis, which I'm trying to correct. And I will just not look at the position of the eyeball as my endpoint if I found the fat to be fibrous to begin with the first cut that I made. And I just hope that it works out. And usually they get a delayed kind of benefit. I don't know how Hamza has found it, or Pallavi, what do you see in your experience as you've come?
Yeah, I agree with you. I think from my teaching understanding is that in these fibrotic cases, because we also see sometimes those serous type idiopathic inflammatory disease, and they have a similar issue. It's you decompress, and early on you don't think you've done much. And for me, from my teaching, I try and focus on getting as deep a lateral wall as possible. Sometimes even exposure of the dura on that lateral wall to try and make the room. But I agree with you. You don't see the results early. If you give them a couple of months, you can actually see some remodeling and the sort of tissue taking up the volume that you've created. The one other thing I've often wondered about these patients is the role for orbital radiotherapy, and whether that would be of any benefit because of the fibrotic component.
I have one last question for the panel. So now that I'm seeing more and more thyroid patients, a lot of times there are these patients who have proptosis, and you know that at some point they're going to need decompression, but they also present with just like a mild amount of strabismus, something like 4 to 6 prism diopters, which is kind of fluctuating, every month that you're seeing them. Sometimes it's 6, sometimes it's 10. So how do you get those patients through that, initial sort of phase? What are the things that you do? And is there anything that we can do for that strabismus, or do you plan for surgery? How do you go about these cases?
So yeah, I'll just say my bit. So what I've started doing is, in those patients who are in that sort of active phase, you're not sure, they're not in the stable phase for rehabilitation yet, and you want to employ sort of techniques or little things that you can do to tide them over until they get there. So for the strabismus cases, what I've started doing is actually injecting Botox to the extraocular muscles to try and get some relaxation of the contractive muscle, which has worked well in the small diopter strabismus cases. So often for the medial rectus or the inferior rectus, sort of between 4 and 6 units of Botox into the muscle belly itself.
One thing which I have noted in these small diopter, small strabismus angle cases is, once you do the decompression, around 50% of them end up not needing strabismus surgeries. So if you wait them out, I have seen that usually the hypertropia ones if you have done a good decompression, the muscle itself gains more access for motility, and the Pulley system gets readjusted in a way that the strabismus surgery might not be needed at all eventually. So this is my experience, but I don't know if that happens everywhere or with everyone. But I usually tell them that you might or might not need a strabismus surgery after the decompression, but we take a call on that only after a couple of months or 3 months down the decompression surgery.
But have you noticed that patients who already have pre-existing double vision or strabismus, that in some cases their strabismus tends to get worse after surgery? Because that's what we read, if you already have pre-existing strabismus, your chances of post-operative strabismus are higher. So how do you kind of, judge what the final outcome might be?
It's very, very difficult.
Pallavi, you are best poised to answer that.
So I agree with what
You're a dual expert.
What Hamza was saying. So I've started doing this. I did it in one of my patients where he had strabismus and a decompression. So for him, I did a maximal decompression, like Adit was suggesting, to create space for those pulleys to come in. But also because he had a very severe hypotropia and an esotropia. So I injected Botox in the inferior rectus at the same time as the surgery. So his pre-op deviation was about 30. And then post-operatively, it was just 10 prism diopters. So I did an additional dose at like a month, just in the clinic. So I think that is useful as a temporary measure, just to tide them over. And they might, like you said, might not eventually need strabismus surgery. But I think I always get confused about those, those 4 to 10 prism diopters, because you don't really know which way they will go. If you inject Botox, sometimes they might just deviate the other side. So I don't have too much experience with that.
So I found they don't go the other way for some reason. It's like those patients who've got like like who have a severe frown. When you do Botox for them. And you give them high units, if the muscle is hypertrophic, it seems to not paralyze to the extent where the eye will go the other way. So,
anyways,
but,
I think,
in saying that, I'm scared to go more than 6 units. So yeah.
well, I think thyroid eye disease is an enigma and one of the least understood pathologies in orbital science, but it was a very stimulating discussion, and I thank everyone, each one of us present here, for taking out time on an odd day. It's a weekday. Everyone has been working, and Hamza is in the middle of his day. So thank you, Raghu. You took time out from your family. Thank you, Pallavi, Milind, and Hamza for joining us here. And hopefully we see you again for more stimulating discussions in the times to come. I also thank team Arunodaya Deseret Eye Hospital and my dear friend Vaibhav for giving us this oculoplastic session and giving us the freedom to formulate it. Until and then, good night, everyone, and have a good time.
Bye-bye. Thanks, guys.
Bye. Bye.
Thanks, Raghu.
Thanks.